Everyone, if I could please ask you to settle down faster.
This G G this G1 G G this G1 G hello G this G1
Okay, start பண்ணுங்க. Hello? Good morning, everyone, and a warm vanakkam and namaste to all of you that are gathered here today. It is a warm and beautiful day for a wonderful convergence. And I hope everyone can hear me till the last, right? Yes. If you can hear me till the last, just raise your hand so that I am clear on you hearing my voice. Yes. Can you hear me till the last? No, I hear a no that is coming. Okay. I'm fairly confident that you can hear me. So thank you to all that have gathered here. And I am Juveria, your host for the day for this convergence. And I welcome you all to the Convergence 2022 International Conference for the Allied Health Sciences, organized by Vijaya Educational Society Academy in association with Society for Nursing Practices and BioLeagues Worldwide with Dharan Group of Institutions, Salem, India. I would like to take this opportunity to welcome some of our dignitaries of the day. Srimati Bharati Reddy, CEO and Managing Director of Vijaya Educational Trust and Group of Institutions, Chennai, India. And I would also like to welcome Srimati Vasundhara, Trustee of Vijaya Foundation, Srimati B.L. Aradhana, Radhana Reddy, Trustee, and Sri Nagi Reddy, Trustee as well. And I would like to welcome our Joint Secretary, Mrs. A. Vimala, Principal, Vijaya College of Nursing, Chennai, India. I would like to give a warm welcome to our Chief Guest, Dr. Amarnath, Deputy Registrar, NIPMED, India. And we also have with us Mr. Rudrabhanu Satpathy, CEO of Technorite Research Foundation, as well as of BioLeagues. And we have with us Mrs. Vijaya Lakshmi, Vice Principal, Vijaya College of Nursing. And I would also like to introduce our other dignitaries, Mr. Emmanuel, Chief Strategist, Mr. Vishwanath Reddy, Chief Administrative Officer, and also I would like to welcome all the other students and presenters who have gathered here today. I would like to invite our dignitaries to please take this stage, and I would like to ask them to take up the seat on the stage. So as I am inviting, I would like to invite Mrs. Srimati Bharati, CEO and Managing Director of Vijaya Educational Trust and Group of Institution Chennai, to take her honorable seat on the stage. Next, I would like to invite our Joint Secretary, Mrs. A. Vimala, Principal, Vijaya College of Nursing, Chennai, India. I would like to invite our chief guest, Dr. Amarnath, Deputy Registrar, NIPMED, India, to take his honorable seat. Next, I invite Mr. Rudrabhanu Satpathy, CEO of Technorite Research Foundation, to take his seat. Moving on, next, I would invite Mrs. Vijaya Lakshmi, Vice Principal of Vijaya College of Nursing, to take her seat on the stage. As we all know, before we begin a wonderful and warm event, it is an auspicious sign that we begin with the lighting of a lamp. It marks that the event goes successfully, and also it wards off all the bad vibrations that come along with holding such a big event. On that note, I would like to invite our dignitaries to kindly light the lamp that we have placed here on the stage, signifying the start of this convergence. May I ask all of the presenters, all the audience to say a little prayer in your heart so that the day goes very smoothly and you're all able to present with the best of your confidence. Thank you to our dignitaries for lighting the candle of the function. Next, I would like to ask the honorable students to kindly present a memento to our chief guests and also to our dignitaries.
Pleasant morning to all. Let me start with the prayer song. We'll have Tamil Thai song. I hope all the students knows. Can you sing this? Just stand and sing the song.
Thank you everyone for participating in that. I think along with the lighting of the candle, the prayer was also a very good touch to our event. It's a sign of all the good things to come for today. So with that, moving on, I would like to invite the students to kindly present a bouquet as a token of gratitude as well as a good sign of presence to our chief guests of the day. I would like them to present a bouquet to Mrs. Srimati Bharati Reddy, CEO, Vijaya Educational Trust and Hospital and Managing Director as well. Next, I would like them to present a bouquet as a token to Joint Secretary Mrs. A. Vimala, Principal, Vijaya College of Nursing, Chennai, India. Next, I invite them to present a bouquet to Chief Guest Dr. Amarnath, Deputy Registrar, NIPMED, India. Next, I would like to ask them to present a bouquet to Mr. Rudrabanu Satpathy, CEO of Technorite Research Foundation. And to Mrs. Vijaya Lakshmi, Vice Principal of Vijaya College of Nursing, a bouquet as a token. I think we can applaud a lot more, right? There's a lot more people in attendance. Thank you. Now that we have honored our dignitaries, moving on, I'm going to talk about the SFNP, the Society for Nursing Practices Association, which is one of the organizers of the day. The Society for Nursing Practices Association is one of the non-profitable professional associations operating under Technorite Research and Development Association, TRADA, meant for research and development in the field of nursing science, nursing education, and healthcare. SFNP, which is shortly known as, is a paramount body which has brought revolution and sustainable development in the field of nursing, neurology, and healthcare. It is a professional association that cares for people around the world. SFNP is an international forum for allied health professionals, nurses, nurse practitioners, research scholars, nursing sciences, and healthcare. SFNP aims to bring together allied health sciences nurses and the healthcare community to encourage intellectual development and providing opportunities for networking and collaboration. About our other organizers, BioLeagues Worldwide. BioLeagues Worldwide is a not-for-profit professional association which prominently promotes research and development. We at BioLeagues have brought a revolution in the field of worldwide conferences. BioLeagues Worldwide Conferences bring together the professional wizards and leaders who have explored all avenues to reinforce the field of life sciences and medical technology. BioLeagues Worldwide conducts events worldwide which help in enhancing the skill set of the people from diverse industries and forms a common platform for eminent personalities, physicians, researchers, doctors, and academicians, professionals, business figures, and much more kind of people. BioLeagues conferences encourage better comprehension about improvements and progressions over the world through worldwide conferences with the speed of science and technology. We at BioLeagues work with our motto of creating a better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achieve sustainable development. A few words to say about our co-host, who is Dharan Educational Charitable Trust, DECT, established in 2017, initiated with the blessings of Shri M. Venkatachalam and Srimati V. Jayammal, which is supported by the management team of Dharan Group as DECT's life trustees. Dharan Educational Charitable Trust, DECT, is one of the landmark initiatives that has been engraved in Dharan industry. In remembrance of completing 10 years in healthcare service to mankind, under the flagship Dharan Hospital since 2007, Dharan Hospital is one of the household healthcare names of Salem district and western districts of Tamil Nadu state in India. Moving on, to say about the conference, the reason that we are all gathered here today and the reason that has united us as well. With an earnest objective of creating an international forum for academicians, researchers, allied health sciences community, and budding students, BioLeagues and the Society for Nursing Practices Association enunciating Convergence 2022 on International Conference for Allied Health Sciences, which is stated on May 14th and 15th, 2022. The conference enlightens on the theme binding and building the gap between theory and practice, a perspective view from allied health sciences. I hope everyone is clear on the theme that has been presented here. Convergence 2022 on International Conference for Allied Health Sciences aims to interconnect the professionals from various parts of the world for an optimistic networking and collaboration opportunities, which will provide you, our audience, with a wonderful forum to refresh your knowledge and will also help you to explore the world of allied health sciences and health. ICAHS shortly is the form of the conference. 2022 will discuss about the perspectives in various fields of focal length is all about retaining a passion for science and technology through the provision of one-of-a-kind solutions. Cardiac technology, nursing sciences, life sciences perfusion technology, medical lab technology, anesthesia technology, OT technology, neuroscience technology, renal dialysis technology, radiography, radiotherapy technology, nuclear medicine technology, trauma care management, physician assistant, optometry, forensic science, echocardiography, healthcare, and many other interesting topics will be covered at Convergence 2022. Does anybody want to repeat what just happened? Does anybody want to repeat that to me? No, right? So as you can see, we have a varied topics that are going to be presented today, and you can learn a lot from them. Today is a day for knowledge sharing and knowledge gaining, and I hope it is a very good conference for all of you. Speaking about the objective of the conference, an event is made so that we know that there is a reason, but it has to have an aim, a goal that we can achieve at the end of the day, something that makes us say, yes, I have done this today. So that is the objective of this conference. Cardiac technology, nursing sciences, life sciences perfusion technology, medical lab technology, anesthesia technology, and all the other technologies as well that has been read out has been the objective of this conference. It is a prestigious event that is organized with the motivation to provide an excellent international platform for the academicians, researchers, nurses, and budding students around the world to share their research findings with the global experts that will be present today. With the reason for the conference established and also having learned about the organizers of the day, I would like to talk about some of our eminent keynote speakers today. So we have Dr. Ashok Kumar Badmali, Senior Consultant, Cardiac Anesthesia, KIMS, India. Dr. K. Lakshmi, Professor and Dean, IC Chettinad School of Pharmaceutical Sciences, CARE, Chettinad Health City, India. Professor Dr. R. Dhananjayan, Head Department of Biochemistry, Apollo Specialty Hospitals, India. Dr. S. Chandrasekhar, Professor and HOD, Department of Internal Medicine, Stanley Medical College, India. Dr. S. Parthasarathi, Department of Anesthesiology, MGMCRI, India. Mr. R. Shivakumar, President, Indian Association of Physician Assistants. As you can see, we have a lot of experts who have been in this field and who have been experienced in this field. They are going to come today to share their knowledge and expertise with you, which will equip you to better handle the world tomorrow. With that, I would like to invite our organizing secretary, Mrs. Bharati Reddy, CEO and Managing Director of Vijaya Educational Trust and Group of Institutions, to take the podium to present her speech about us.
A very, very good morning to all of you. You have a long day to go, so don't go to sleep so early. Respected dignitaries on the dais, respected dignitaries of the dais, ladies and gentlemen, and my dear students.
I'm indeed very pleased to welcome all of you to this first International Hybrid Conference, Convergence 2022 at Vijaya Educational Academy, Chennai, in association with Society for Nursing Practices, BioLeagues. Am I very loud? This conference is focused on a multidisciplinary program with broad participation of members from in and around the globe, focusing on learning about various facets of allied health science research. It is high time that such an event has taken place to highlight the remarkable contribution which allied health science makes in so many areas of our lives. A special welcome to Mr. Rudra Banu Satpathy, the CEO and founder of Technoret, Technoret Research and Development Association, and also member of IFERP and IEEE. Sorry about that. We are proud to be a part of your association, sir, and hope we would be united in the future for the same. We also welcome the director, Mr. Siddharth, BioLeagues Technoret Group. We also extend our special welcome to Dr. A. Amarnath, Deputy Registrar, NIPED, with the National Institute, Registrar in the National Institute of Employment of Persons with Multi-Disabilities, NIPMED. Cordially invite all the speakers and delegates from across the world to attend this conference. It creates a perfect podium for global networking as it brings together renowned speakers across the globe to the most exciting and memorable scientific event filled with informative and interactive sessions. Convergence 2022 will provide a tremendous international forum for sharing knowledge and results in allied health science. The event focuses on providing participants from diverse fields with unique and rational opportunities to create a need for themselves. This conference will provide best globalized opportunity to reach the largest assemblage of participants from the scientific community and research. It also helps to explore every nook and corner of advanced concepts in allied health science with experts from all over the world. 12 interactive sessions will be carried out for 2 days, followed by Best Research Award and Best Poster Award. This Convergence 2022 develops professional skills and builds new partnerships with associations and industries. I would like to express my sincere gratitude to all the keynote speakers, which have already been mentioned by our MC. I don't want to repeat the same. It is an opportune moment to refurbish and debate upon the problems of mutual interest with our esteemed delegates from all over the globe. The conference schedule brushes upon a spectrum of exciting and benefiting themes being discussed. On behalf of my institution, Vijaya Educational Academy and Vijaya Medical and Educational Trust, I welcome all the research scholars and paper presenters from various parts of the country. All their papers would enlighten us all. Before I end this note, I would like to mention and congratulate the person who is the backbone of this entire conference, Dr. Gopinath Subramanian. I think give a round of applause to him. If you are sitting over here, it's only because of him. So I thank you, Mr. Gopinath, for making this event and especially making your contribution will be really valuable and create an insight in our endeavor to reach out to more patrons around the world. Thank you very much. Namaste. Jai Hind.
Thank you, ma'am, for your speech. I think it was a short speech, but I think she thanked all the right persons and gave a round of applause to all the people that are involved in this convergence. So thank you for the special mention. Next, I would like to invite Mrs. Vimala, Principal of Vijaya College of Nursing, Chennai, India, who's also the co-organizing secretary as well. Mrs. Vimala has a 25 years plus experience. She has published 25 papers in index journals. She also has clinical and teaching experience that almost makes up for the 25 years. Ma'am, it is an honor to have you here with us. I invite you to kindly take up the stage for your speech. Planning for a year, sow rice. If you're planning for a decade, plant trees. If you're planning for a lifetime, educate people. So it's a great pleasure for me to welcome our Honorable Chief Guest, respected correspondent madam, respected trustee members, vice principal, teachers, speakers of the day, BioLeague teams, delegates, and dear students from various institutes throughout the world who came here to exchange your experience, knowledge, and to collaborate together. We are indeed much privileged and excited to organize our first hybrid international conference on binding and building the gap between theory and practice. I would also like to thank our beloved correspondent madam for all the enthusiasm, initiative, focus, and energy in bringing out this day at its best. So may I now request Mr. Rudra Bhanu Sadapati, the CEO and founder of Technorate, to honor our correspondent madam with memento. My further thanks for who greatly helped in organizing the conference, Mr. Rudra Bhanu Sadapati, the CEO and founder of Technorate Research and Development Association, and so I extend my heartfelt welcome to you, sir. May I now request our CEO, ma'am, to felicitate our Mr. Rudra Bhanu Sadapati. A special welcome to our chief guest, Dr. A. Amarnath, Deputy Registrar, National Institute for Employment of Person with Multidisabilities. So a person with simple, humble, and dedicated person. We welcome you, sir. May I request our correspondent madam to honor with memento. I would like to thank Director Mr. Siddharth for helping us in organizing this function. So I would like to thank Mr. Gopinath Subramanian for his outstanding contribution in arranging and organizing and coordinating with this entire conference and making it more successful. I would like to call upon Mr. Gopinath onto the stage. I'd like to request Mr. Sopinath to come to the stage. I request our CEO, ma'am, to honor Mr. Gopinath.
So in today's scenario, the need for healthcare professionals are mostly wanted and increasing day by day. And as education institution plays a great eminent role in molding the students for the same, keeping all this in our mind, we have organized this Convergence 2022 to update the knowledge, to build and bind the gap between theory and practice, from which the students will be benefited in the clinical area. Listening to any prominent personality in any seminar or conference would help the student to gain vast level of information about how they have to work and how things fall in clinical area, and also presenting a poster and paper would make them gain confidence in their soft skills, which will be valuable in their academic career. This also adds a greater focus on the flip side of learning new things to relearning classic techniques. However, conference provides a unique convergence of networking, learning new ideas, enriching and upgrading the students' knowledge. Keeping all this in our mind in association with Society for Nursing Practice, we are much privileged to organize today's conference, and we are sure all the students will benefit from this. Hope each of you will be benefited by this day. So I extend a very, very warm welcome to all the persons, all the delegates, dear students from all over the world. So, and I extend my thank and my teachers who have supported this team to this programs. Thank you so much. All the best for today's event.
Thank you, ma'am, for your speech. I think it was a very warm welcome and a wonderful speech she has given. I would like to mention that it is such an honor and a privilege to see your colleague being appreciated for his efforts and for his energy that he's put into the conference. I think our CEO, sir, is as well as happy to see the appreciation of such efforts that happen. So on behalf of me, as well as from our organization also, our congratulations to Mr. Gopinath. Moving on, I would like to next invite a special address by Mr. Rudravanu Satpati to address the audience on his take of this Convergence 2022. Sir, it is my honor as well as my privilege to invite you up here to the podium.
A very good morning to everyone. Esteemed dignitaries, respected speakers, revered guests, honorable management of this renowned and esteemed institution, respected faculties, organizing committee members, scientific committee members, national, international, and institutional ambassadors of Society for Nursing Practices, and my loved students. On this esteemed day, few moments of my childhood days are reverberating in my mind. We all have passed on our childhood days looking towards moon on the laps of our grandparents, with millions of dreams, smiles, and happiness in our eyes, and looking towards the fairy tales and stories of Chanda Mama magazine. Now, we all will be wondering, why are we talking about this at this scientific forum where leaders and eminent professionals are gathered to share their expertise? There are many students and faculties in this conference hall, those who have come from other institutions, and I would like to make them aware the most prestigious, popular, widely circulated children comic magazine, Chanda Mama, which was released in 7 languages, in all regional languages, was first initiated under the leadership of the founder of Vijaya Educational Group. So, a humble prayer to his shoal of leadership. India is an ancient nation and has been always a leader in healthcare and educational sector. Vedas and Upanishads of our ancient times speaks about the impact of diagnostics and treatments during Diden period of Charaka and Susruta. And few lines of Charaka Samhita is reverberating in my mind that speaks about a culture, a community that serves the entire world. So as our Bhagavad Gita says, Sarve bhavantu sukhina, sarve shantu niramaya, sarve bhadrani pasyantu ma kaschid dukha bhavet. And India today is leading in this respect. We were able to provide vaccinations to more than 71 countries with 585 million doses of vaccines when the entire world was striving for COVID-19 pandemic. And when the educational system of physical meetings and physical conferences was jeopardized due to restrictions of physical gathering, Society for Nursing Practices, a unit of Technovarit Research Foundation, came forward for organizing virtual conferences because our commitment of uninterrupted academic services is directly connected with the perspectives of safety, security of humanity that focuses toward United Nations goal of United Nations Development and Educational Program. So as the theme of the conference, bridging and building the gap between research and practices, irrespective of allied health sciences. At this point, when we look into the gap that diversifies the applications of research in respective of three dimensions, three verticals. One is monitoring the progress. Our community, our association is constantly monitoring the progress of available infrastructure, scopes, opportunities, requirements in field of education, sciences, healthcare sectors by organizing these type of conferences, and we do publish articles also in our journals. The second thing is being prepared or building capacity to adopt shock. COVID-19 pandemic has made us learn the priority that we must give towards the shock. And the healthcare system of our nation should be ready to fight with upcoming predicted shocks, and the educational systems and the research systems should be rebuilt and revamped with these type of activities through professional networkings so that we make ourselves ready to contribute to 20 lakhs, 22 lakhs of shortage of allied health science professionals all across the globe. These things will be possible if we work towards capacity building. Capacity building should be practiced at the ground root level, at the grassroots level. We are constantly insisting the students of allied health science professionals to be a part of our organization through a student membership so that we can groom them, we can train them about the opportunities, about the scopes of the research and how their work could be submitted to necessary forums, publications, and funding agencies where implementations and trials could be done. We are being supported by more than 60,000 plus professional members in different fields, national ambassadors, institutional ambassadors, those who are relentlessly supporting us to make this type of activities and goals successful. We insist institutional chapters establishment in different colleges and universities. I urge faculties and researchers from different corners to be a part of these countries because I believe integrating professional that is proportional to third dimension of United Nations Organization's goal is the most important aspect. We are in a verge of establishing the world's largest scientific community that will operate with technology in virtual forums. So we hope by next year, virtual associations will start operating and that will mobilize this type of activities. Our R&D team and our technology team is relentlessly working on this. I urge institutions, universities, and colleges to be a part of our journey, to integrate with us and establish institutional chapters, because I believe globalization of innovation is the most important thing. When we go back to a couple of decades, there are very few number of activities and conferences were organized by universities and institutions. There were a lot of formalities, a lot of processes, a lot of procedures that we need to apply for the government fundings, because arranging funds and organizing this type of conferences was a tedious job. We felt knowledge is everyone's right, and availability and scope of international knowledge should be provided to the grassroots of the nation also. We moved to different states, developed and developing, different districts, different subdivisions, blocks, to the rural areas also. We communicated with everyone. We communicated with young professionals, young researchers. We brought their ideas, and we thought that they deserve the optimum scope of knowledge related to research. We started organizing this type of activities, workshops, faculty development programs, conferences, and we got speakers from all across the globe. We have today international speakers as well. And this could have been possible by the organizing committee members and the scientific committee members and all associations members we do have today. My heartfelt gratitude to the entire team of Society for Nursing Practices for taking this leadership. And I do not have enough word to thank you all to join this conference at a very short notice of invitation in such a large number. I hope this conference will be a fruitful event, and there will be a lot of scientific opportunities and scopes of interactions, and I believe our organization will meet your expectation. In upcoming days, I believe all researchers will be integrated in a common forum so that we can bridge academia and industries. We can bridge interdisciplinary research. So bridging academia and industry is one of the important factors, and bringing interdisciplinary professional to a common forum is very important. We will be really glad to publish your articles also. If you have very genuine and good articles, unique articles also, it could be submitted for the conference publications also. That could be done. I wish everyone a very great day, and hopefully these 2 days of first physical and second day of virtual conference will be a fruitful event for you. Thank you very much.
Thank you, sir, for your speech. I think he started off in a very visionary way, and he ended with a wonderful gratitude to everyone that is involved here. I could see that many just listened with a lot of intent, and I hope that continues for the 2 days. So I would like to ask Mr. Rudrapanu Satpathy to please felicitate our principal ma'am, Mrs. Vimala, with a memento. Yes, you can applaud. I would also like to invite Mrs. Bharati Reddy, CEO and Managing Director of Vijaya Educational Trust and Group of Institutions, to felicitate Mrs. Vijaya Lakshmi with a shawl. Thank you, dignitaries. Moving on, next, I would like to invite our chief guest, Dr. Amarnath A., Deputy Registrar, NIPMED India, to deliver his special address.
Good morning. அனைவருக்கும் காலை வணக்கம். It's my great privilege to be part of this important Convergence conference on 2022. I welcome all the dignitaries on the dais, students, practitioners, ladies and gentlemen. By design, I'm a deputy registrar, but basically I'm a rehabilitation professional and teaching faculty. So I can talk even 45 minutes without audience also. Yes, that is the one of the important quality of the teacher. Never see what student speaks. We want whatever we can talk. Yes? Okay. When I gone through your the Convergence 2022, when the paramedical or the allied health professionals, when they go and work in the hospital, you are expected to work under the supervision of the doctor, or you are expected to work under the guidance of a doctor or diagnosis and other things. But it's entirely different in rehabilitation sector. The professionals of allied health is expected to use their knowledge to practice in the rehabilitation. Nobody is there to guide you. Nobody is there to teach you what you are going to do for your child with cerebral palsy, or a child with autism spectrum disorder, or a child with intellectual disability, child with, now we have a 21 types of disability, I can say, because we know all these conditions. Why I'm telling you this? Any professional, we want to bridge the gap between the theory and practices. I feel it's very, very important that students or practitioners should have the reflection on what you are going to do with the case or individual. This theory is not going to give it you. Theory will give a trigger, a basics for you, but that will not help you to find a solution or give you a proper services to the individual. It needs a reflection. This reflection can come in 3 ways. That is what we feel in our rehabilitation professionals. First, very important thing is you should develop interpersonal skills. That interpersonal skills, how you are dealing with the individual, how you are understanding the issues, how you are reflecting the issues in your mind, that is very, very important. Second thing, your professional skills, how you are making a decision or diagnosis, or what you are going to finally do with your interventions. We never call it as a treatment, we call it as an intervention. What intervention you are going to plan, whether it's useful for the client, because any practitioner, any service provider, any academician, any technical person, anything, the final outcome is improve the quality of life of the person and improve the ease of the problem. When we talk about the professionals, please develop all the way from 4 to 6%. That is what I feel. Dipmed is standing can be good. That's whoever doing the report or any other alert, please for one time have provided a money. Lessons and your professional skills. That is very, very important here to respect gap. And third, very important for you, communication. Communication should enable also, your communication should empower also. Your communication should not discourage the individual. That is very, very important.
So if you follow this, I'm not saying this is the only thing, it's my practice, my experiences, the practice what we are doing for 20 years, 25 years, we are doing the teaching and the practices. These are the things are very important to bridging the gap between the theory and practices. The theory we are learning in order to serve, to provide this practice. Is very important. I hope this convergence, this conference will help you to have different things in your life. That is the way they say that if you do regularly what you are doing, you will get whatever regularly you are getting. Do something differently, you also get different results. Otherwise, your life will be monotonous and a routine, no changes in that. Try out new thing, do something different, so you will results also different in your life. That is what your great learning. Even if you make mistakes, don't worry. Mistakes only make you to perfect in your future. So when it comes practice, do anything new, and as a professional, our aim should be help the individuals. As a practitioner, better you open up all the ways and learn from all the ways. Don't limit anything within yourselves. With the few words, I once again thank to the organizers for providing me this opportunity. Thank you very much.
Thank you, sir, for your speech. Next, I would like to ask our sponsors, Nice New Tech, a representative, to please say a few words.
Good morning, everybody. I'm Anusha, clinical executive at Nice New Tech, and I'm happy to represent the company here in front of all of you and in front of the respected dignitaries. So this event is actually a great platform for students to, bridging the gap between your technical stuff and your educational aspects. I really respect the ideas of everybody who organized this committee. So Nice New Tech has been here for 25 years, and we've been doing NICU equipment like for babies, newborn babies. And we have been functioning with the vision of making infant mortality rate to a complete zero. As every day, there are 6,000 babies born and dying every day. So we want to bring that numbers down to zero, and we are happy to coordinate with doctors, nurses, healthcare professionals, because we are only making the tools. They are the people who are using it and bringing meaning to what we do. So we are working hand in hand with doctors, nurses, and every healthcare professionals out here. And we are really happy to be a part of the event, because we believe students are what the next future is. So getting to introduce ourselves, getting to know that people are being interested in technical stuff as well is really happy for us. So thank you, ma'am, and thank you everybody for giving us an opportunity. And for students here, we've also have exhibition outside. People interested can just come, and you can ask us any questions. We'll be happy to teach you, and we'll be happy to even tell you how everything works. All right. So it's a basic step of how we take in bringing students to the next level of getting to the industries. And we really thank you the opportunity, and thank you, ma'am. Thank you for the organizing committee. Thank you.
Next, I would like to ask the other sponsors, CBS Publishers, a representative from the company, to say a few words. I am inviting a representative of CBS Publishers to say a few words. All right, moving on. So there is a special mention that we would like to give one of the organizing team members. So for that, I would like to ask Mr. Rudrabanu Satpathy to please facilitate Mrs. Yashashini of Technorite Group India, who's been working for this conference, to felicitate her with a shawl. Can I please invite Ms. Yashashini? Ms. Yashashini, can I invite you to the stage, please? Okay, thank you, Ms. Yashashini, for coming to the stage. Kindly please applaud for her effort and energy she has put into this conference. With that, we would be concluding the inauguration ceremony that has happened. And as a mark of closing the ceremony, we would like all of you to please stand up for the national anthem. So I would like to invite all of you to please sing along with the national anthem. Before our dignitaries step off the stage, I would like to ask that we have the book release of the conference proceedings that's going to be happening. So I invite the dignitaries to kindly please release the conference proceedings. May I ask the dignitary to please display the book for the audience? Next, we have CBS Publishers and Distributors. A representative of the company would like to say a few words.
She's opening that is we are giving from Narrate from Ansesthesiology, education.
Ah, okay. Association. I think everyone is eager to know what was in the packaged covers. Next, as a token of appreciation from the Technorite Group and BioLeagues to Vijaya Educational Academy for their wonderful cooperation with us, I would like to invite Mr. Rudrapanu Satpathy to felicitate Mrs. Bharati Reddy with a memento from our side. Thank you, dignitaries, for your wonderful presence. You've really marked the conference. Can I ask you to kindly step off from the stage so that we can prepare for the next sessions that are going to happen with the conference? Can I please invite some of the student organizers and coordinators to come up to the stage to help prepare for the next session? Can we have few volunteers to help out, please? Meanwhile, I would like to request the audience to please take a 15-minute refreshment break. So the refreshments are available in the dining hall. Kindly please assemble back here by 11:05. That is 11:05.
So this. Two.
Once again, I'm asking all of the audience to please come back to the hall as we are going to start the keynote sessions. So as you are all settling down, we would be starting the keynote session, and we do have a lot of keynote speakers today who will be addressing the audience on a variety of topics. May I request the audience to please settle down as we begin the keynote session? May I ask the audience in the back to please settle into your seats as we are starting the session now? Okay, thank you, audience. Once more, a very good morning to all of you. I once again welcome you all to the keynote session that is going to be happening. On that note, we have a lot of keynote speakers today, and our first keynote speaker is Dr. Ashok Kumar Banamali. He is an ambitious, task-oriented, and committed individual interested in cardiology, anesthesia, education, administration, and research fields, striving to utilize his capabilities in development of institution and profession. He's currently a senior consultant in Kalinga Institute of Medical Sciences, Bhubaneswar, and has an experience of 28 years in this field. He completed his MD anesthesia from MKCG Medical College, Odisha. He has had more than 30 publications in international journals and has given 25 plus keynote talks in national and international conferences. It is my pleasure to invite Dr. Ashok Kumar Manamali to take the stage for his speech.
Good morning to all. Since it's already getting delayed, so thanks to the organizer for taking initiative. So I am happy to see a large participation from all category, mostly students, because everybody's either professional or personal life starts from a studentship. Every day is a studentship day. Throughout your life, have the mentality of studentship and be in the jolly mood. But at least during sessions like this, keynote sessions, hands-on session, and other interactive session, please maintain silence. Can I get 10 to 15 minutes silence? Okay. Because in spite of this speaker, in spite of this sound system, the large mass chorus chaosness is obscuring both my thought and my voice. Okay, so myself, Dr. Ashok, the moderator has already told about me. So few more things I want to disclose. So mostly besides this cardiac operation theater and ICU, 50% of my time I spend every day in training. We have a training center and simulation center in Orissa. It's called Kabil. It's the meaning empowering somebody. Kabil means Sakhyam. Okay, we empower the skill of the paramedics, and most likely our institute may be the only institute where there is a dedicated simulation lab for the nurses and paramedics. Besides these doctors and other things. So we have to fight a lot with the management for these things. Then they could also realize if an institute is containing a cost structure of 700 or 800 crore, but 85% of its staffs are paramedics and from allied science. I may be wrong. It may be up to 90% in some cases also. So the paramedic staffs are with the patients, with the patient relative 24/7. We doctor usually take the round, then went for various other activity. So if someone has to develop the skill and quality of service of a hospital, then obviously the paramedics training, skilling, reskilling, upskilling, many things are there. Okay. Next, please. Okay. And depending upon that, during my training to the paramedics, they give us an idea that, sir, you are teaching out basic life support, advanced life support. What will happen when you will not be there? Can you assure we can perform up to that mark? So then we come up with a common device called Sanjeevani QCPR. So instead of this manual CPR, where the rate, depth, and recoil should be optimized according to American Heart Association, we have come up with that device, and that got patented, and now it's a complete ecosystem. On April 7th, World Health Organization started its first medical innovation hub at Vijaya. The innovation hub head congratulated to our team for this innovation, and thanks to my paramedics team who have given me the idea for coming up with this innovative structure. This is the cream of empowering the support system. So what is, my topic will be on palliative care for cardiac and perfusion related things. Since most are students, when I came to know that, I changed my slides little bit to make you it more interesting, and one may find some slides are repetitive. I have deliberately kept that as repetition because the point of focus where one has to learn the key point, because it's the keynote session. The key take home points, those were repeated intermittently. While we will going through the slides, you can perceive that. So what is this palliative care? According to World Health Organization, the active total care of patient whose disease is not responsive to curative treatment, control of pain or other symptom, and of other psychological, social or spiritual problem, it's coming under the gamut of palliative care. So why to involve in palliative care? When my question that we have so many of hospitals, so many of primary health center, secondary health center, tertiary health center, even quaternary centers doing transplant, other things. So what is the necessity of this palliative care? Initially, okay, 20 years before, 10% of hospital beds were ICU beds, 90% were general beds. Scenario is getting changed. Now, more beds are in ICU. Everybody has seen the effect during the COVID pandemic. More intensive care is required. It's because of the age-related change, chronic lifestyle, accessibility to better health care. But hospitalization is not everything. And there are certain things where the patient or the sufferer has to be with the family. That gives better comfort than the hospital treatment itself. Okay. So people with unresponsive heart failure and other malignant presentation of coronary artery disease receives appropriate palliative care and support. So it is the need. So the active total care of patient whose disease is not responsive to curative treatment, control of pain and other symptoms. This is the palliative care for everything. What for cardiac patient with heart failure, that is non-responsive to medical therapy or drug therapy. So it needs the patient and the caregiver. Caregiver may be the family member, caregiver may be a professional palliative care or from allied science. So they should be identified, assessed and managed at an early date with the available opportunity to discuss issue around the uncertainty and sudden death. So someone who has born will die one day, but with a disease, there is the agony, there is the psychological pain, but family and the patient should be mentally prepared for that. That is also a component of palliative care. So there is the unmet need. Unmet need means scope is there. That is the basic behind discussing the topic, basic behind organizing such conferences. So substantial evidence for considerable unmet palliative care need for patient with heart failure and their caregivers. Then the management of chronic heart failure in case of primary and secondary care. So what are the main area? Main area is symptom control, psychological support, social support and planning for future, and finally the end of life. So this worsening heart failure, what are the symptoms of worsening heart failure? Most common symptom for which the person or the family member comes for hospital consultation or any palliative care consultation is increasing shortness of breath, breathlessness or increasing shortness of breath. Then second is fatigue or weakness, worsening kidney function, pain. Pain is not always physical or neurological. It may be having the psychological aspect also. Then the low mood or depression, loss of appetite due to cardiac cachexia, incontinence, that is the irregularity in bowel bladder habit, immobility, then confusion or disturbed sleep pattern, and poor response to the ongoing drug therapy. So how to manage this breathlessness? Usually opioid is preferred for, it has the two component. One, it suppresses the rate of respiration so that the breathlessness is compromised, breathlessness is managed. Second is a sense of well-being is there. So palliation of symptom of heart failure depends with treatment of opioid and diuretic. Diuretic means the drug which increases urine output, or so by doing that it decreases the body fluid, decongest the lung and decongest the gastrointestinal tract also. Because of the congested digestive system, many times patient will complain that I don't have adequate appetite, I don't have the power to digest, fetal affluence is there, and obviously because of that nutritional deficiency, muscle wasting, that cardiac cachexia finally sets into. So opioid has indirect benefit in those segment also, because when someone is breathless, so he or she cannot swallow properly also. Okay. Then while considering the increase in breathlessness, consider other possible causes of breathlessness other than heart failure. So it may be the infection or it may be development of a pneumonic patch or pneumonia also. So take the detailed history, thorough assessment, whether it is sudden onset or slowly progressing over days, then chest examination and underlying cause, whether further attack or recent myocardial attack has been happened, or is there any rhythm disturbance or arrhythmia, anemia due to nutritional deficiency, pleural effusion, or there might be thyroid issue, or diuresis or diuretic may need further adjustment. You need to increase the dose of Ditor or Lasix or any other acetazolamide which is given to the patient. That has to be again reassessed. Then titrate the dose of opioid. Why? Because it has the side effect for constipations, sedation. So always consider prophylaxis laxative while giving opioid to the patients of heart failure. Another constraint in Indian scenario, many of the state getting the opioid by the family member, getting the opioid by the paramedic staff is also due to the licensing restriction also. So because of that, this association should have some connectivity with the hospitals, so the patients under home care for this palliative care, under them, they can get the opioid from their concerned hospitals. So advice, what I have told till now for controlling the breath was the pharmacological treatment. There are also non-pharmacological treatment for this breathlessness. So it is fan, backrest, elevating the back with back support, then oxygen therapy, intermittent non-invasive ventilation or BiPAP, and we can ask the person to do few times pranayama to decongest the lung and increase more lung recruitment. In normal breathing, when you take the respiration, air goes up to mid lung. So lower part are collapsed. So while taking this incentive spirometry or deep inhalation or pranayama, lungs goes up to the base. So it prevents the atelectasis, use better lung component so that oxygen saturation and signs of breathlessness subsides with that also. So try both drug and the non-drug therapy. Then another thing we were seeing in the list was depression. I will not be cured of this disease. I am getting hospitalized repeatedly. My son's or my daughter's income is going out in my treatment. So this is the depression or anxiety. And another stress is that my life has come to an end stage. So these are the component which leads to depression. Okay. So I will take more times here because 30 minutes or 40 minutes before one of these chairperson were telling about this communication. what is lacking with we doctors? We less communicate with the patient. So because of the less contact period, larger patient to population gap, another thing, other ancillary duties, but for the patient relative, it's 100%. So we have to give more time. So it's the palliative care team who has to communicate. Okay. The communication may be in a storytelling manner. I have written that red one. Okay. So consider trial of antidepressant, SSRI or any other after discussing with the psychiatry specialist or psychologist, and refer to psychologist and consider CBT. CBT is cognitive behavioral therapy. So many of you might have come across this story of Maharaja Parikshit. Okay, he was the last king from this Pandav dynasty. Okay, he was cursed that a snake will kill you after 7 days. Because of this curse from one of the sage. Suppose, think the psychological stress on that king. My death is coming after 7 days. So that was the mythologically documented cognitive behavioral therapy. Then he come across various sages. Mostly they told various stories from all the avatars of Lord Vishnu and other things. So that constitute our Srimad Bhagavat. The person was engaged throughout the 7 days, curiously listening the stories from various sages. So that was the cognitive therapy. So he forgets at the last time, if someone of you might have read Srimad Bhagavat in the last stage, he was totally motivated. Yes, I have come with a life. Now my death is near, but I am not depressed. So that's the thing. Okay. So one has to motivate. And another thing, encouraging the home care therapy. Anyway, institutional therapy will be costly. If someone is worried about the things, so we can think for this non-pharmacological treatment and institutional or home care therapy along with the instruction for this worsening signs. Yeah. With this symptom, you can only come to the hospital. Rest of the thing you manage at homes. So that will take care of his psychological component up to a larger extent. Because one, you are elevating the cost. Second, he or she is with the family member. So the sense of getting doomed, sense of getting ill is not there. Okay. So again, as I have told, I will be recapitulating the symptoms. What are the worsening symptoms and what are the most common symptoms you have to tackle during the palliative care for a heart failure patient? So the anxiety management, then pacing, because many of the patients, because of the heart failure and rhythm disturbance, they might be having the permanent pacemaker or CRT or CRTD device. So then the symptom control, symptoms we have already discussed. Then provision of walking aid, listening to them, psychological support and providing a relaxation method. Energy conservation, refer to other services, as I have told, nutritional service, psychological service, physiotherapy service if needed. Then managing the activity of daily living, care support and exercise advice. Okay. All patients, because of the low protein heart failure, they will be having pedal edema. Many times, in spite of protein, appropriate protein, serum protein level also, they will be having pedal edema. So no need to give the advice of let's do some serum albumin, let's do some serum protein. If you are aware of that, then tell him to take this back rest, elevate the foot. Then it may be due to the drug amlodipine given for the BP control. That might be the cause of this leg swelling. Think all these factors. What is this edema? Means swelling of the both legs. It is due to heart failure. It might be due to renal involvement. It might be due to low protein or serum albumin level. So diuretic is needed as a palliative care method. Diuretic means the drug used to increase the urine outflow. So combination of various diuretic, salt or fluid restriction every day one has to convince the person for restriction of fluid and salt. So there comes also the need for psychotherapy or discussion, because when you are restricting the fluid, the sensation of thirst will be there. When you are restricting the salt, in one end he or she is anorectic, appetite is not there, and you are making the food tasteless by restricting the salt. Nowadays, many of these companies have come up with low sodium also. So we can think for that. Then positioning or elevation of the bed and care for the bed sore. If someone care for the pressure area to prevent bed sore. If someone is bedridden, then there is a probability of development of bed sore or decubitus also. So proper skin care has to be there. Another symptom is that there might be cough. The cough is due to the drug. Many times AC inhibitors, drug, telmisartan, olmesartan, these drugs are there. So they cause also cough in some persons, but it might be a cause of infection, pneumonia or heart failure. So if cough is there, then simple any cough syrup 5 ml TDS will work for that, and elevating the posture, nebulization with normal saline, which can be done at home also. What is the advantage of nebulization with normal saline and gargling with normal saline? We are restricting the fluid. So the thirst sensation due to the oxygen therapy, due to the increased breathlessness, the person takes breath from the mouth. So mouth get dried. So sensation of thirst happens many times. So if the thirst, you are not able to convince him and elevate the thirst sensation, then they will not be cooperative anymore. So nebulize with normal saline. Then another complaint the palliative caregiver has to address is pain. So consider pain other than heart failure. It may be musculoskeletal pain, a joint pain or musculoskeletal pain. More than 70% of time the pain is musculoskeletal. And we can use the component of psychological, spiritual and emotional support for controlling the pain. Okay, pain is not always somatosensory. It may be psychological also. So involve other team members. Then the analgesia, the analgesic ladder is there. First thing for non-steroidal analgesic like paracetamol, diclofenac or any other thing. But in this case, because of this renal involvement, those drugs are given at lower dose. Then think for opioid in the high position of the target. Okay. Then another complaint the heart failure patient gives. One was anorexia or loss of appetite. Along with that, nausea and vomiting. Means sensation of vomiting is there. It is due to the congested digestive system. It is due to the digoxin. It is a drug, digitalis or digoxin, prescribed to the heart failure patient to maintain the rhythm. So side effect of that is also nausea and vomiting. Amount of medication. So many medications are there. There is a drug for diabetes, for kidney, for BP control, 2-3 drugs are there. So after observing so many drugs, many times patient is also getting nauseating or vomiting. So we have to think for any combination drug to reduce the number of tablets. That gives another psychological benefit. Yes, now I am taking 4 drugs. Earlier I was taking 9 drugs. It may be a combination. Same drugs may be combined to 4. But the patient will be having the psychological thing that, yes, my drug is reducing so that I am improving. Okay. This also reduces the nausea and vomiting sensation and the patient compliance per se. Cardiac cachexia, this means lean and thin body structure. It is due to the tumor necrosis factor delivered, and patient may have poor appetite, that is inadequate digestion, inadequate sense of appetite, congestion of the liver, congestion of the GI system mainly leads to this. So one has to give this diuretic, then second, digestive enzyme if needed, and finally maintaining the appropriate protein diet. what is the appropriate protein requirement per day? In case of adult, it will be 0.5 to 1 gram per kg per day. Suppose an adult of 50 kilo is there, so at least 50 gram protein from his or her homemade foods we have to supply. In the absence of adequate protein, there will be muscle wasting, there will be more manifestation of this cardiac cachexia. Then how to manage further? Except this nutrition and drug, attention to the details, refer to the dietitian, and if tolerating or if the person is taking non-veg also, then fish oil can be adjusted. I have already discussed the component of dry mouth. It's due to the restriction on salt, restriction on fluid, and excessive diuretic. In one end, we are removing the body fluid through urine. Other way, we are restricting the daily intake and the salt. So, if oxygen therapy is also there, all these things get intermixed and create dry mouth. So, the sensation of dry mouth is very irritating. Then the patient will not be that much cooperative. Okay. How to elevate that? By normal saline nebulization and gargling with normal saline. Not to drink, but gargling with normal saline, that oral mucosa is getting moist, so the sensation of dryness is gone. Okay. Many times, not only the diuretic or other effect, fungal disease or any other oral pathology might be there. So if the person is complaining of dryness, then examine his or her mouth, whether any infection is there or it's due to the fluid deficiency. Okay. Further that, if he or she is comfortable, then give the sucking ice and sugar-free gum. Okay. So the more saliva by chewing gum, sugar-free chewing gum and sucking the ice cream or gel, so more saliva secretion will be there, the sensation of dryness will be reduced. Because of the pathology in the digestive system and because of the opioid, there is symptom of constipations. So reduce the fluid intake, opioid, breathlessness, dietary fiber, lack of dietary fiber, this leads to constipation. So stool softener or laxative is routinely advised. But in this case, this polyethylene glycol or Movicol is not used. So what is the agenda? Whether to go for treatment or go for supportive treatment. So the supportive agenda suits to the end stage illness, coping with the symptoms and uncertainty and the fear of dying in the hospitals. Okay. Then you have to give the supportive treatment to a larger extent instead of this therapeutic treatment. Why do heart failure patients end up dying in hospital? In spite of these so many awareness for this palliative care and other things, because of the primary physician, they are getting exhausted. The family member is over enthusiastic or they get panic, or communication of death is not anticipated to them. That's why they repeatedly take the person to the hospital. So if I am seeing that this patient is not going to improve, then I have to explain, yes, be prepared for the end stage. This will be the symptoms. These symptoms are extreme. So in the extreme situation, don't be panic and bring the patient to the hospital, because that is the point of no return. So in that case, getting hospitalization is not going to give benefit to the person. Okay. So what are the palliative care we provide in the heart failure? First, the diagnosis. Then if death happens, how to diagnose the death? Because here the caregiver are mostly paramedics also. So to declare and to diagnose the death, and if the cancer component is also there, how to adjust the cancer palliative care along with the cardiac palliative care. So this is the main take home message from my talk. a joint approach should be there, partnership between primary care, secondary care, in collaboration with nursing staff, medical staff, and allied personnel. So it's a total umbrella. Rainbow cannot be found with one color. Okay. So everybody's contribution is needed in that segment. So how the allied science or the paramedics, they can develop their palliative care skills by skilling up with the generalist. Sensitive and honest open communication is essential. Why I am telling this open communication? Because what is the disease or pathology trajectory? What is going to happen next? How much it is going to cost? So those things has to be discussed with the relative and the patient, so that they will be openly minded to take the further decision. Yes, up to this level we will go to hospital. These things we can do at home. With these things we can call the primary physician and think for any other higher center hospitalization. Okay. I was telling about the psychological component. The terminally ill feels unknown more than the known. Okay. Professional dishonest more than professional inaptitude. The process of dying is more than the death itself. So the sense of doom or the fear of doom is much more painful. Okay. This is the Liverpool care protocol, which is usually told to the patient or the relative. For the last 48 hours, the team decides that patient is dying and the communication is done to the family. It may be either at home, it may be either at hospital. Because just to, it's not, you cannot tell it's at euthanasia. It's the establishing DNR order. That DNR, many of you might have not come across. That is that do not resuscitate, because we know the end stage. So no active CPR, no active drug or intervention is done in those cases. Since we know the consequence that he or she has written the point of no return, so just support till the end of life is there. So in those cases, non-essential drugs are stopped, and stopping inappropriate investigations, blood test, or any intervention things. Okay. So again, I am repeating those as I have told in the beginning. So what are the symptoms one has to address as a palliative caregiver? In the breathlessness, pain, abdominal fullness, then the early meal satiety or the indigestion, then palpitation or the racing race, or that is the rhythm disturbances, cachexia or the muscle wasting, then the sleep disorder. Okay. So how our act as a physician is contributing to the symptom? Many times you will having a patient with these symptoms, but it may be due to the ongoing treatment. Been ignored much more than the cancer palliative care, because the constraint on access to the resources, heavy reliance on cancer-based charity. Much more charity is for cancer-based end-stage treatment, but this charity for this cardiac palliative care has not gone up to that level, and existing service is overwhelmed and poor defined disease trajectory. Okay, so heart failure patient may succumb within 1 month, may stretch up to few years also. So inappropriate and inadequately defined disease trajectory. So why this inappropriately defined disease trajectory? Numerous clinical scenarios are there, an unpredictable response to treatment due to the fluid and electrolyte imbalance. So okay. What does the general palliative care involve? Once again, assessment of the patient and the caregivers need for their support, information to the caregiver and the patient about the disease trajectory, about the worsening sign, about the facilities available, psychological, social and spiritual support and the practical approach, and situation where and when they can be referred to a specialist consultation. So I am skipping those few slides. Okay. So finally, what can be done at home for the palliative care? So why I am telling for this home, as you have seen even this during the pandemic, initially the contact were taken out by the police person for in the name of contact tracing. When the hospital gets filled, then they change the guideline. No, only the positive person will be in the COVID. Then symptomatic positive will be. Then only severe positive will be there. So when the case number will be increasing, obviously the guideline will be changed by default to a home-based therapy. So in that case, at that time, maximum care burden will be on the palliative care and allied science who are doing home-based treatment. So why it is going to come? Because of the increased incidence of diabetes, renal and coronary artery disease. That CAD is coronary artery disease. So in those cases, only one has to think for if there is a life-threatening ECG changes or patient is collapsing, then only come to the hospital. Rest of the things, because of the technological advancement, ECG can be done at home and can be sent to the cardiologist or sent to the physician for their opinion whether we should admit the patient or not. Earlier, for taking an ECG, person was taken to a ECG center or to a hospital. Now it's home-based treatment. Giving the oxygen therapy, it's home-based treatment. Giving the concept of e-ICU, then it will obviously come into home ICU like concept. One of the hospital will be monitoring all the palliative care patient in their vicinity. Yes, here this is the Vijaya Institute. It will be monitoring 5,000 patients under palliative care with a digital platform. So those things will come in the future. Patient number 1,000 is worsening, call them or tell them the treatment that these things can be done. So these are the upcoming innovations already in the pipeline. So we are in the early adopter phase. Getting a pulse oximeter during my post-graduation day in 2005, 3 OT will be fighting. You have taken my pulse oximeter. You have taken my BP instrument. After this COVID, pulse oximeter was available at a cost of 1,000 rupees. So once demand is there, obviously cost will reduce and utilization will be there. So this nebulization during my MBBS days in 2000, one person will be getting nebulization, 3 person will be in queue. After this person, second will be getting nebulized, third will be getting nebulized. So during the year 2000, cost of nebulization per setting was 75 rupees in government hospitals. Now everybody has their portable nebulization. So things is going to change. And for this pain, visual analog score was the only score. There was no objective score. Okay. So few algorithms have been developed from the patient's body sign, from the objective signs of the body, from the heart rate variation, from the ECG changes, from the facial grimacing. Due to this artificial intelligence component, the machine is detecting, yes, the pain component is this much. It will facilitate in delivery the opioid to the target level. So bioengineers are making our job much more easier. NIVP, digital NIVP, almost many affordable families, they are keeping their own NIVP, this blood pressure, digital blood pressure, weighing scale, own nebulization, own home oxygen concentrator. So many things are there. So it will not be an outburst on my part to say that after 5 or 10 years, India will be self-sufficient in this device segment and this adoption segment, that most of the palliative care will be home-based treatment. And because of this digital platform, one doctor will be catering. So many medical colleges are coming up. There will not be much more job. So what the MBBS person will do? Obviously, they have to be again coming back to the patient, primary patient care. So suppose I will be MBBS doctor in 2030. So my job will be to give palliative care to around 2,000 or 3,000 patients in around my area. So I don't need any major infrastructure. Patient will be in their home. Patient will be in their home. Supportive team will be with them. So I will be monitoring them. When and where required, I will give that treatment. So this segment, the Western countries, they are also trying to adopt because of their insurance cost. Nowadays, we have entered into insurance sector because of this Ayushman Bharat and various state government scheme. So once that insurance burden will be much more, obviously then guideline will change. Let's go to the home-based treatment. So prior to that, the manpower or the human resource has to be developed. Machine can be manufactured with automation. 1 minute earlier, one machine was made. Because of the automation, 100 machine can be made. But we cannot make this much of skilled person over 1 minute. So it will be a planned and timely job. This milestone wise, we have to groom up our workforce. Okay. Then the pranayam to reduce stress and consider BHP and diuretics at home, because in case of urological problem, only the bladder distension and inability to urinate, it's the only emergency. In old age person, mostly the urine incontinence or inability to void the urine because of the benign hyperplasia of prostate. That's there. In one way, we are increasing the urine, filling the bladder with the diuretic. In other way, patient is not able to void the urine. So those things can be managed at home. So let's think for a better palliative care at home. India, we are known for our 150 crore population. Service sector wise, IT sector has done its job. Now it's the health sector has to show its potential. So you all are the next level skilled manpower who are going to support and give the service to the society. With this, I am concluding. So if anyone has any doubt, then we can take one or two few questions. Okay. Thank you.
Thank you, Doctor. So if there are any questions, we'll take a minute or two. If any of you, yes. So we have a lady here in orange who has a question.
Hello, sir. My name is Gomati. I've been in healthcare for nearly 25 years. So actually, this is not a question of where I just wanted to give a comment. Like you talked about BPH here, benign prostatic hypertrophy. To my knowledge, no one has addressed this issue. We talk about diuretics. We talk about decreasing the volume, but no one has given attention to this. And this obviously speaks your experience, like how many patients you've encountered this way. Can you give some more thoughts to this?
Thank you, ma'am. Actually, many times when we are deliberately creating a hurdle situation and expecting a better outcome, so I will squeeze someone's throat and ask his or her to sing a better song. So it's like that. I am creating excess urine, but because of the age-related change, there is the prostate mucosa which is blocking the urethra. The person is not able to void the urine. So two things are there. So if the narrow is up to the extreme level, then urologically that is advised for continuous silicone catheterization. The silicone catheter can remain up to 3 or 4 months. Another thing, but in that case, daily urine, bladder, this bladder and bowel care has to be there. So bowel care and bladder care, bowel care for with this laxative, bladder care, one has to clean the catheter with antiseptic, preferably chlorhexidine or with fresh normal saline. How to keep the catheter care? Many of the audience might have known, but I will tell 2 words on that. So if it is the catheter, suppose the catheter is here and the urethra ends at that position, it may be a male or female. By pulling the catheter to a little bit and from up to outside, clean twice, so that the colonization of bacteria and further ascending of the bacteria creating urinary tract infection will not be there. First thing. If it is a mild to moderate case, then one can use this nail cath or disposable cath just to deflate one time. Okay. Since we are discussing for palliative care, so in this case, I will not suggest for this treatment of TURP. That is the transurethral resection of prostate, which is done for other cases. Here, since we are proceeding for end-stage disease and palliative care, so TURP will not be a treatment of choice in this case. Either suprapubic cystectomy or silicone catheter, but with a focus on daily bowel bladder care. Why I am telling bowel here? Because the fecal matter or the E. coli from the stool, that is the main source for urinary tract infection. So if you are not taking the bowel care properly, then patient may land into urinary tract infection after 4 or 5 days. I think this addresses your question. Oh, thank you, ma'am.
Cardiology conference, and there's no genetist approach to it. So they never talk about this problem.
Cardiologists, they are busy in the cath lab.
Exactly.
So I look after the OT and
Their talks on heart failure is mostly on heart failure drugs and whatever. And this is a very practical.
Those 5 things I have told in the symptoms repeatedly. This is the drug induced. So before addressing the symptom with another drug, can we reduce the drug? So I am giving opioid for the pain. So that opioid is creating constipation. So instead of increasing the Dupalac dose to 6 teaspoons, 7 teaspoons per day, can I reduce the opioid? Can I add little bit of NSAID or paracetamol? Can I add some teens or nerve stimulation therapy and psychotherapy to reduce the pain with low opioid? So these things should be titrated. Okay. Thank you.
Thank you, doctor. So do we have any other questions? So I hear a few no's. Before we proceed, I have a humble request to all the audience over here. So when the speaker is speaking, we hear a lot of murmurs from behind, and I do not want to point it out, but if you could please maintain the silence, it would be really helpful to the speakers as well as to the other audience who are listening in. So it is a humble request, please do consider. I understand everyone is sitting in groups and it is a very tempting thing, but please hold off for a little while, so until the speakers are done. I think the doctor's speech was informative and we've had a question from the audience as well. Moving on, I would like to welcome our next keynote speaker, who's Professor Dr. R. Dhananjayan, Head of Department of Biochemistry, Apollo Specialty Hospitals, India. Educated in MSc Medical Biochemistry, Faculty of Medicine from PES Institute of Medical Sciences and Research from Chittoor, District of Andhra Pradesh. Affiliated to Dr. NTR University of Health Sciences, Vijaya, first class with distinction and a university rank holder. PhD of Medical Biochemistry, Faculty of Medicine from Nizam's Institute of Medical Sciences, NIMS, Hyderabad, Telangana. He has an experience of teaching in MBBS, BDS, and other health sciences for a totaling of 20 years and 2 months since 2001. The teaching experience in MBBS, BDS, MDS, BSc Nursing, BSc MLT, DPT Allied Health Sciences, Diploma and guiding PhD students Consultant and Head of Department of Biochemistry at Apollo Specialty Hospitals, Banagaram, Chennai. Various levels as Professor, Associate Professor, Assistant Professor, Lecturer, Tutor cum PG at different medical colleges and institutions, that is Apollo Hospitals Education and Research Foundation. PES Institute of Medical Sciences and Research, ACS Medical College and Hospitals, Sakshi Medical College and Hospitals, Thai Mugambike Dental College, Apollo Institute of Hospital Management and Allied Sciences, and Apollo College of Nursing. So I would like to invite the Professor Doctor to take up the podium for his speech. As mentioned before, we do expect a good conduct from everyone that is over here. So thank you. Hello.
So good afternoon to you all. So I think almost now 12. So if it is around 1 o'clock, I'll be in little trouble because you will be in hungry, and I think I can, in between 12 to 1 is okay, I think. Okay. And as a student, I can make out like these kind of conferences for you to concentrating is a little difficult, but as a allied health science and nursing, you are a professional students, and there is a good scope in the near future. So 5 years before or 10 years before, now hardly we can see some 2-3 very few allied health science students, but wherever you go, that AHS, it has got like many people, it is almost like equal to IT or other profession, people are trying to join. So the purpose of this conference, or the purpose what we talk, all these things you come across in the future, in your future or in your future profession. And my topic, this is like good clinical laboratory practice. You may not be involving directly with this. So one thing you try to understand, as an allied health science, many of you will be thinking, so I am an allied health science profession, or I'm not a medical laboratory technologist. I am doing my like OT technician, or I'm doing my physician assistant, or like cardiac care technology, whatever it is. So you will be thinking, so why this particular topic is needed for me? So one thing you try to understand, whether an MBBS or BDS or nursing or allied health science, the pathology is same, the anatomy is same, the physiology is same. So what it is taught for an MBBS, the same thing is taught even for you. So the concept is same. The purpose is, suppose in future you are working. So by seeing a patient, you should be able to make out like what kind of problem, like what is wrong with him. So little knowledge you can have it. So for that, it gives an idea. So why the laboratory medicine is important? So laboratory medicine is a diagnosis. So diagnosis in the sense, a patient is having a diabetes mellitus. So by only with the help of the laboratory, you can make out the patient is having diabetes mellitus or renal failure or whatever the disease he is having. Okay. So to monitor, so after giving the treatment, you can monitor whatever the treatment you are giving. So that works out or not, that can be easily made. Then good clinical laboratory practice. So everybody is practicing. Why there is a separate GCLP? So it means nowadays, when compared to earlier days, there is a difference between earlier days and like even our time and your time. There is a lot of difference in the technology, in the development. Now the documentation. And second thing is, so the systematic, there is a system. So earlier it was nothing like that. Just like that it will go. But even in your syllabus, or when you get into any of the corporate hospital or any of the hospitals, then nowadays there is a system. So there is a particular system you have to follow, the standard operating procedures. So for that, the laboratory medicine is very, very important. Okay, so you all know that. So you will be thinking that lab means only sending the sample and then they'll give the report. So what is the various processes? So there is a registration, how a patient he registers in the hospital. Similarly, there's a separate reception in the laboratory, the registration, sample collection, and then sample is transported to the laboratory and receiving the sample, and then it is processed, and then whatever the report you got it, whether that particular report is correlating or not. So that is done, interpretation is done, and then at the end, the report is released. So you should know all these things, even though you are not directly involving all these things. So you should know the various processes, what it happens in the laboratory, being a allied health science profession. Okay. So like the management, so nowadays in the maybe after 2000 or 2010, that management or the IT, these kind of terminologies are applicable to every field. So management MBA is not like it is a separate, it is applicable for each and everything, whether a clinical or paraclinical or paramedical, whatever it is, the management is very, very important. So for example, the quality. So quality means what? The person, whatever the laboratory value it is given to the patient, whether it correlates or not. For example, a diabetic patient. So he is having a elevated sugar. So it has to be properly, it should be reported. So once if the patient is taking a medicine, what happened? The value, it has to come down or it has to be monitored properly. So for that, there should be a proper quality and there should be a proper management in the laboratory. So documentation, as I told you already, so in your syllabus also you will be studying, each and everything is documented. So only if it is documented, if at all, if any error happens, you can make out. So what is the reason for the error and how it can be corrected and how it can be prevented. So for this purpose, the documentation is very, very important. Okay. So how you can improve the updates? So as I told you already, now most of the things are online and technology is improving day by day. So just by sitting in the college or just by sitting in the working place, you cannot improve your knowledge. So you should keep on attending many conferences or CMEs or workshop. So by that, what is happening in the world? So what is happening in outside and how you can update. The same thing, it is applicable in to the laboratory also. And again, the audit. Nowadays, anything you take, the audit has become a very common. Any of the hospital you go, the audit. In the sense, are we doing in a proper way? We are doing things in a proper way. So that has to be checked. So only that you can give a quality reports. And again, what is required? So allied health science, already as earlier speaker, he said, the skills are very, very important. So now these many people are there in the sense, for you, the theory is one part. Another part is the skill. So how skilled you are, so that will be added to your CV. So apart from your what you call syllabus, the skills are very, very important. So how much you know, so that is very, very important. Okay. And this particular thing, you should know that, see, for example, you are a physician assistant. So when you see the this thing, patient history or whatever, the patient is getting all the record. So for example, lipid profile or cardiac markers, only value you will see that. But very important thing is, what is the previous value? What is the now value, whether the treatment has been given or not. After giving a treatment, is there any improvement? Or after giving the treatment, the value should not be elevated again. So these are all the things it should come to your mind. So for that, these are all the things you should know that. So in the laboratory, three things are very, very important. Pre-analytical, analytical, and post-analytical. It means before it enters into the lab, that is a pre-analytical. Analytical in the sense, what is happening in the laboratory, how they are testing all those things. And then post-analytical, after they test it, whether how the report is released. So these are all the three important things in the laboratory. So pre-analytical, you must be knowing, like what happens when a patient goes to the hospital, when he meets a doctor, and then he will write for some of the investigation. Then he will go to the, he will go to the sample collection place, and then he gives a sample. So sample is taken, and then all is, whatever all the SOPs are followed properly or not, it is checked, and then the sample is sent to the place where the analysis is taken. That is nothing but the central laboratory. So any sample, it is a pathology or microbiology or biochemistry, whatever the sample, it reaches the laboratory. And again, sample, the very important thing is the sample is proper on. See, many places it happens. Patient name will be different. Sample will be different. So sample mismatch. That is one of the important error. It happens in the pre-analytical phase. And again, sample may be collected some 3-4 days before. It is not properly stored. Maybe because of that, values will be wrong. Okay, this is another error. And it is not transported properly, or there is a hemolysis. The sample is not drawn properly. So these are all the errors associated with the pre-analytical stage. Now analytical phase. Analytical phase in the sense, the instruments are working properly or not. Okay, whether the QC system is fine or not. Are they doing a quality control properly? So depending on that, the analysis, whether it is a perfect or not, it is very, very important. See, how many of you go for postings, clinical posting? How many of you have gone? I think almost all of you would have gone. So what you will do there? Simply standing and watching. Huh? So that is the only thing we can do, sir, because they will not allow anything else. Huh? Because even we get a lot of allied health science students, morning 9 o'clock if they come to our department, so they'll be seeing their watch when it will become 3 or 3:30. Yeah? Maybe most of the time, most of the places, the same thing will be happening. But the thing is, during that time, what you can do, you can notice what the people, what the staff members are doing. So what is their day, morning to evening, what they do. Okay, so that you can notice and you can write it. So these are all the things. Again, you will not get this opportunity, and entering into as a student, entering into your laboratory or entering into your hospital is very easy. But after that, it is very difficult. You have to get a lot of permission, approval. So when, as a student, for a posting, whenever you go there, so try to utilize properly. At least what kind of instrument is there? What is the use of that? What they're doing? It's a basic thing. You don't have to learn each and everything. You don't have to learn the procedure. That and a later part. What is the use of this? So what is this? What is this? So like that, each and everything. What is the purpose of that? At least that you should try to know that. So nowadays all automated. So not only laboratory, every instrument, whatever the instrument in the hospital you come across, everything is automated. Now the manual methods are reduced. All like software related. For each and everything, separate skilled people are there. Separate software engineers are there. Biomedical engineers are there. So our role, it is focused nowadays. It is like more specific than the earlier days. So earlier days, we used to concentrate in each and everything. Now, like instrument pod, so it is taken care by the biomedical engineer. So similarly, what are the different kinds of professions they work in the hospital? You should know that. What is their job responsibility? You should know that. Okay. So now, one thing I'll tell you about the instrument. So whenever you go to the posting as an allied health science student, you will see now there are so many instruments are there. So what you see, the people are using the instrument, they're getting some report from that. So that you know that. But before that, the instrument, when they buy the instrument, or have they installed properly? The installation is very, very important. The installation is, and whether is it working properly. So many, it is tested before itself, it is verified. Okay, whether it is doing well or not, it is done. The quality is checked. The quality, and then we will analyze, we will check with our known sample or known patient, whether it is functioning properly or not. That is first thing it is done. Then if it is okay, then it is used for all our patients. And then every day it is maintained. Is it working properly or not? So that is maintained. And again, reagent. So reagents, whatever the reagent or glove or the tube, whatever it is there, it should be properly used. There should be a proper expiry date. Before expiry date, it should be done. And then the thing should be indented properly. Even during this COVID time also we have seen. So suddenly many patients, if they come, many places people were not able to handle. So properly they were not able to indent the things. Okay, only with a single glove, people are handling many things. So these are all the things are not supposed to happen. So it should be properly planned. So indenting, not only for laboratory, for anything, the proper indenting and proper planning is very, very important. Otherwise, suddenly if the patient load is more, it is very difficult to face the situation. Okay. So in the hospital laboratory, the instrument and proper usage of the instrument, and there is a standard operating procedure. Standard operating procedure in the sense, in one particular department, 5 staff members are there. All 5 staff members should have the same methodology, using the methodology. That's a standard operating procedure. But earlier days, it was not like that. One person will follow different method, another person will follow another method. It is not like nowadays. It is systematic. It is already pre-planned and it is defined. So you should follow that standard operating procedure. You should learn that. So that will improve your quality and that will give a efficiency. So that is very, very important for good reports. And again, quality. So we can compare our quality with some other like hospitals and laboratories like a CMC or AIMS. So with them, we can compare. And again, sometimes the errors will happen. Okay. Maybe if you are working in a small setup, if you do error, so people, maybe some places people leave. But if you work in a good setup, so people will easily catch you because everywhere there is a documentation. Okay. That is the root cause analysis. So whether who has done the error. Okay. So it is easily done. And then in a error, there are 2 things. One is the random error. Another one is systematic error. Anything, any department. So these 2 things you try to remember. Random error and then systematic error. It means random error in the sense, maybe once in a while it may happen. It will not happen every time. Randomly it would have happened. But systematic error in the sense, the system itself is a wrong. If the procedure itself is a wrong means, whether you do it for 10 times or 20 times or 2 months or 3 months, there is always an error. So that is a systematic error. Okay. And then post-analytical. Once by using a blood sample or any pathological sample, if the report is ready, and after that report has to be released, then it has to be correlated. Suppose a patient is normal, the sugar value has come 400. So you cannot release it. Or a patient is like pre-dialysis, his creatinine is normal. So these are all the errors. It takes place even after the analysis, before they release or before they verify the report. So these are all some of the errors it happens, so that it has to be interpreted. So that is the reason what will happen. Patient today history. So what kind of problem the patient is having. If you have any doubt, you can call the nurse and then you can check it. And again, there is a read back policy. Read back policy in the sense what? What I am calling and who is there in the opposite side. So it is noted, it is documented. So that if any error is there, it can be avoided. We can catch the people. So common error in the laboratory in the sense, maybe a wrong sample will be there, or maybe the instrument may not work properly, or the quality control, it is not, the QC, it is not checked, or expiry, the reagent or kit, it is used in expiry. And again, if the training is not given to the people. So these are all some common thing. So this, even after your interpretation, see, because why I am telling this, many times people will come across, whenever we have a meeting, this value is not correlating, that value is not correlating. Patient is not diabetic, but sugar value is elevated. Patient is normal. Patient is not having this trouble. This parameter is elevated. So to make out that, at least you should know what is behind that. You should know that. Then root cause analysis. So why? So 5 W's you should remember. Okay, what is the reason? Who has done it? What may be the reason? So you have to find out what is, suppose if any error happens in the healthcare system, you cannot leave it just like that. Each and every, even a small error, it is accountable because it affects the patient. So you have to find out what is the root cause. Then you have to correct it. Suppose if at all, if any error, you have to correct it, and then you have to prevent it. So next time it should not happen. What? You can do that. So that is a preventive action. And again, this 5 years, it is more common in every department. Like you have to sort it out. So when you enter into the department, it should not be haphazard. Even any auditors are coming, you have a document, within 30 seconds, you are supposed to get the document. Okay. So sort, set in order, shine, standardize, and sustain. So when you work in the hospital, you will come across all these things, and there is a safety also very, very important. And again, the very important thing is like safety is very, very important. Whatever you throw it, so whether you throw it a food wastage or paper, stationery wastage, or any what you call infectious wastage. So depending on the color bag, you have to throw it. So you're supposed to follow that. So that is the biomedical waste. So there are different color code. So that particular color code you have to follow. So stationery wastage, you cannot throw it in the yellow cover. So that is very, very important because nowadays for each and every accreditation, these are all the things it is followed. And again, fire safety. See, this is also each and every person in the hospital, you should have a knowledge. Suppose if there is some fire, what should happen? What will happen and how you have to react it? Where you have to assemble? Where is the common assembly zone? And so that is generally we call it as a RACE, rescue, alarm, confine, and evacuate and extinguish. Okay, these are all the things you will be given training in the hospitals. And again, pause, like pull, aim at fire, squeeze the extinguisher, sweep. This each and every one in a hospital, you should know that you will be given training. Suppose it's some fire accident. So how to react and where you have to assemble. You should know where is the assembling point, all these things. Okay. Then the quality. So quality means what? See, almost we have come to the climax part of the talk. Okay. So now I have to tell silence, silence, silence. You don't like silence, you avoid silence, but we like silence. So we can't avoid it. Huh? Okay. So, because in the conference we can't avoid, so we like it. So quality means what? It's a simple word.
If somebody is watching us, so I want to be perfect. Okay, my principal is coming for rounds, so I want to keep quiet. Okay, my principal has gone somewhere, so I can dance or I can do something else. So that is not the quality. Even if nobody is noticing us, okay, what is our job responsibility? That if we do that, that is known as quality. What is SOP? What is quality? What is the thing? It is defined. What is my job? If you do it as an allied health science professional, you have a better future.
Open. You can ask the doctor for any of your doubts. You can have them cleared. If you do have doubts, please just raise your hands so that we can identify. All right. As we've had no doubts, moving on, we would like to welcome the next keynote speaker, Dr. S. Chandrasekhar, Professor and Head of Department of Internal Medicine, Stanley Medical College, India. Educated in MBS 1995 at the Stanley Medical College and Hospital, Chennai. Diploma in Diabetology 2002, Stanley Medical College and Hospital, Chennai. Dr. S. Chandrasekhar is one of the best diabetologists in Chennai who earned an MBBS and Diploma in Diabetology from the Stanley Medical College and Hospital. He has more than 20 years of experience. He has won the Best Doctor Award in 2011, and he has also had 37 indexed journal publications and resource person in national and international conferences as well. As you can see, he is a very distinguished speaker. So I invite Dr. S. Chandrasekhar to take the podium for his speech. As usual, kindly please maintain the decorum and code of conduct for this hall, and silence, please. Thank you.
Good afternoon to everyone. At the outset, I would like to thank the Vijaya Education Academy and Society for Nursing Practices, Mr. Rudra and Mr. Gopi for having me here. Next half an hour, I'm going to dwell upon some of the important clinical cases which we commonly see in the emergency ward. So this is going to be the bread and butter for most of you. So if you do not know how to take care of a sick patient in an emergency situation, it would be a big disaster, not only for the medical care, but also for the patient and patient attendant. So I just wanted to have your attention for the next half an hour on this very important clinical thing. So we all know that, like, I'll start with two perspectives, though my talk is, I'm supposed to talk on the interpretation of the ECG, echocardiogram, CT scan, and ABG. So what I thought is, first I dwell a little bit on the how we can receive a patient, particularly a patient with the altered sensorium, and what we are supposed to do as a allied health personnel. So that is more important. Then we can move on to my second leg is on the interpretation of the ECG, echo, and other laboratory things. So I hope the slides are visible from the back, and my voice is also audible. So we all know that, like, our brain requires the oxygen and glucose to thrive, to think, to survive. So if it is disturbed, like the patient, they get into a state of unconsciousness. So unconscious means like not that like the person is lying non-responsive. So they can have various things, like they can have a brief LOC that we call it as fainting, or syncope, or if it is prolonged, we call it as a deep comatose state. So the etiologies are many, like in an emergency situation, like when we receive a LOC patients, they can have multiple etiologies, starting from your trauma, your stroke, tumor, infections like meningitis, encephalitis. Some of the common, if you're diabetic with, can present to you with the LOC with the altered, with the hyperglycemia or hypoglycemia, certain electrolyte abnormalities like hyponatremia, drugs poisoning, all these things can cause a LOC. So remember that the patient can be non-responsive, but at the same time, the patient can have a little bit confusion, drowsiness, sometimes stuporous to start with, and later they go into the loss of consciousness. So you've got a variety of symptomatology to present when a patient is having a altered sensorium, okay? So this is a thing. So the most important thing is when you receive a patient, so you need to assess the patient. That is more important. I think the neurological assessment that can be done at the bedside is the Glasgow Coma Scale. So what is it? I think most of you know that, and you should know how to interpret this Glasgow Coma Scale. So this is the Glasgow Coma Scale. I think you need to take the 3 variables, the eye response, verbal response, and motor response. So which you need to take and you need to score it, okay? So if somebody is normal, of course, all of you know it's 15. Somebody is having a GCS of less than 9. It's an indication for starting a support, even a endotracheal intubation. So please remember that. So as the severity, the number goes down, the severity of the brain injury is also high. Now, this is I think the most important thing all of you should know. So I just want to dwell on so what are all the things which is expected of you when you receive a critically ill patients? So this is a very important thing, like maintaining a patent airway. So this is a very important skill all of you should have. And you should check the breath sounds every second hourly and assess for the cough and swallowing reflex. And if the patient is continue to have desaturation, the patient might require some kind of support, respiratory support in the form of mechanical ventilation. And more important is the change of positioning. So that is also more important when you are going to have a patent airway to a sick patient. So in addition to that, they may have a collection of fluid inside the mouth. So the oropharyngeal suctioning, so periodical oropharyngeal suctioning for every second or third hourly is the most important thing that we call it as oral toileting. So if you don't do, there would be a possibility of collection of secretions and the possibility of aspiration. So that is a very important endangering condition, particularly when the patient is having a altered sensorium. And another thing to make sure that dentures are removed. Sometimes if they have any dentures, they are at risk of developing again aspiration. So nasal and oral care is more important thing that every one of you should perform when a patient is having a LOC. The second thing is when a patient is sick, the maintenance of the intake output chart. Strict intake output chart is a very paramount importance because that would determine the possible therapeutic and prognostic implication. See, most of the time what happens when the patient is having an altered sensorium, they'll be put on they'll be given some IV fluid containing dextrose solution. But be careful with the continuous infusion of dextrose solution without monitoring, because this can result in increased in the intracranial pressure sometimes, particularly when the patient is having a stroke kind of thing that can aggravate the condition. So please remember that the infusion of intravenous fluid that should be under close monitoring, and only if necessary it should be given. In most of the cases, we need to encourage the early enteral feeding through Ryle's tube. This is another problem when somebody is having a LOC. So we need to maintain the skin integrity. So how we can do that? we need to keep changing the position of the patient. So that is more important. Suppose if the patient is a hemiplegic patient, so the hemiplegic portion should be on the top. Okay, so suppose if the patient is having a LOC, where you may need to make sure that the upper limb and the lower limbs are almost in line with the shoulder and the hip joint respectively. So this is a very important thing. You need to maintain the head in the neutral positions. Otherwise, what will happen? If the we'll see most of the time the head is bent like this. Okay, so when it happens, they may have some kinking of the carotid that can impair the blood supply to the brain also. So make sure that the head is in the neutral position. So this is one of the important things. You need to have specific mattresses. Of course, in all the ICUs, they have some specific mattresses, alpha bed, air bed, a water bed kind of thing. So that should be given to prevent the bed sores. And the most important thing is early enteral feeding improves the survival of the patient. Please remember, it's a very simple thing. By giving a early enteral feeding through a nasogastric tube, that is Ryle's tube, it can improve the survival of the patient. Of course, the risk of injury, so the patient should be adequately protected. The side railing should be kept in the right position. And of course, if the patient is likely to develop a seizure, you need to prevent the iron rods or gadgets or electrical appliances nearby so that they should not injure themselves. This is also another very important thing in a very sick patient or in patients with LOC, the monitoring of the bowel and bladder functions. That is one of the very important thing. Make sure that the urine chart is maintained and they have adequate bowel movements by giving laxatives. This is again a very important thing. So once the patient is sick, we give a Venflon IV access either through a peripheral vein or through a central vein. The second thing is we usually catheterize the patient, put a Ryle's tube kind of thing. Or sometimes if the patient is having low oxygenation, we connect them to a endotracheal tube or CPAP or mechanical ventilation kind of thing. So please remember, all these devices are invasive devices and that can make a person at risk of developing infection. So make sure that your Venflon is changed at least once in 3 days. Once the patient's general condition improves, you take off the Ryle's tube, you take off the catheter or any devices for that matter. That is more important, or try to change it. Okay, so I've seen many times like in the ICU where the Venflon is kept and the intravenous access is kept in situ for more than 7 days, 8 days kind of thing. That should not be done. And the IV access, particularly the Venflon, should not be given in the lower limb because it can result in, again, the risk of developing catheter-related infections. Please remember that. I think this is the most important thing, not that only a doctor would do a counseling kind of thing. You should take the responsibility because you will be with the patient all the time and taking care of these patients. Please explain to the patients and the patient's attender about the situations. Okay, so that is a very important thing. So that would solve many future crises to happen. So now I come to the second part of it. Okay, so we have seen how we can receive a patient with a LOC and what are all the things we are supposed to do. I think that's a very mandatory things we are supposed to do. And now we go to the next part of it. That is what are all the basic investigations which we can do on these patients and how to interpret. I think I know that it's a mix-up crowd. So I just want to dwell on the very basic things. Okay, I'll take another 10 to 15 minutes to complete that. So this is the ECG tracing. We all know that the PQ, RS, G waves, and the importance of it, I think you all know that. So when you are interpreting the ECG, the most important thing is check the name of the patient and the time and date. So this is more important. It's very common to have common names. Somebody by name Susila, they may have 2 or 3 Susilas kind of thing. So the age also should be mentioned, the IP number, so the patient's ID number. So all these things should be entered in the ECG. So there should not be any mix-up of the ECG. That is the most important thing. Okay, so next, we need to check the calibration. So we all know that like the 10 millimeter is equal to the 1 millivolt. So we need to check the calibration, that is 10 small squares. So whether all the ECGs have got right calibration or not, because that can influence the width of the diameter of the ECG waveforms. And of course, the pepper speed, we need to ensure that the patient is having the normal pepper speed, that is 25 mm per second. So how do we know that like the ECG is taken in a right way where the limb and chest leads are set up correctly? So this is a very important clue whereby we come to know that if AVR is negative, you are possibly right. You are taking a right ECG and the lead one is always positive. So this is also another thing which can help you to find out whether this is a right ECG or not. And R wave progression from V1 to V6, you will have the progressive increment in the length of the R wave. So that we call it as R wave progression. So this is a normal ECG. You could see the R wave progression from here. Okay, so the AVR is negative here. Okay, so the V1 is positive, and we could see the R wave increment. Okay, so as from V1 to V6, we could see the R wave increment. So this is a very simple method by which we can find out whether we have taken the right ECG or not. Of course, we all know that the reciprocal representation of the heart. 2, 3 AVF represents the inferior wall, V1 and AVL, and V5, V6 represents the lateral wall, V1 and V2 represents the anterior and right ventricle, and V3 and V4 represents the anteroseptal wall. So this is again a very basic thing, because nowadays we do see a lot of cases of myocardial infarction. We know that ST elevation is a marker, ECG marker of the myocardial infarction. We can, depends on the site where you could observe that ST elevation, you can find out what is the type of infarction the patient is likely to have. The problem is we may sometimes see a lot of artifact. Let us begin with some of the problems, common problems we see in the interpretation of the ECG. So this is an artifact which you could see here. So all the waveforms are, if you see the lead 2, where the waveforms are normal, P wave is followed by QRS complex and T wave. Whereas if you could see here, the one lead, where you could see the artifact. Similarly, like the tremors of the muscles, where you can have some the variations in the QRS. Similarly, you may have some electrical interference where you can get a patchy or blotchy recording of the ECGs. So these are all some of the very common abnormalities or the observations we see in the interpretation of ECG. Now, let us briefly dwell on how we can measure the rate, the heart rate, okay? So if you take the RR interval in large square, say for example, if you have 4 large square in between the 2 RR interval, 300 by 4, the heart rate is 75 per minute. So I think this is a very important thing. I think from people from beginning, they should appreciate this ECG. It's a very simple thing like by which you can find out the heart rate of the patients. The second thing is the patient may have different types of heart blocks. I think you can go through in your text also. I'll take you to some of the important thing. The LBB, so this is a very common thing where you observe the W pattern in V1 and a M pattern in V6. Please remember that your new onset LBB might indicate that the patient could be having a myocardial infarction. So whereas this is a RBB where you could see M in the V1 and the W pattern in V6. It could be normal in 30% of the individuals. So this is a very important thing. All of you should know how to interpret, at least identify a ECG with myocardial infarction pattern. So you may have some T wave abnormalities, T wave peaking, and a ST elevation in the leads. This is an example where you could appreciate the ST elevation in lead 2, lead 3, and AVF suggestive of inferior wall myocardial infarction. This is a very common arrhythmia we see in all ICU patient emergency situations, the atrial fibrillation. You could see, so you could see the waves, the fibrillatory waves. So seesaw-like, so waves. So that is a very typical where the heart rate is irregular. You can see the heart rate, which is irregular with the seesaw pattern, suggestive of a atrial fibrillation. This is a life-threatening arrhythmia, that is ventricular tachyarrhythmia. Of course, these things also we see, it's a benign one, the ectopic beats. So this is a ectopic beats, this is a benign one. So you should remember some of the normal ECG parameters, the rate, axis, and intervals. So you need to know it by heart. So now I take you to a echocardiography. So the thing is, the principle is very simple. Suppose if you shout into a well, the echo comes back a little bit later, a moment later. Similarly, you generate sound through the transducer and you receive it. So this is a very simple analogy by which an echocardiogram can operate. Of course, it's an age-old technology. Nowadays, we do have a lot of applications, not only echocardiogram, but ultrasound also in all the ICU. So the POCUS, I think most of you people working in ICU, they may know the importance of POCUS, point of care ultrasound. So this is a echocardiographic machine, and you have various pulse generator, transducer, receiver, display, and memory to store the display. So this is how you do that. And these are all some of the positions which you see: the suprasternal, left parasternal, apical, and subcostal. I'll briefly tell you like some of the important views which you should know. This is the apical 4-chamber view, where you keep the transducer in the apex of the heart, and it should be towards the left shoulder, where you will be able to see the left ventricular outflow tract obstruction. So similarly, this is a 2-chamber view, so that can give the free wall of a left ventricle, the anterior as well as the inferior wall. So this would be more useful to find out the regional wall motion abnormality. So this is a subcostal view where you keep the transducer in the xiphisternum towards the left shoulder, and it would be able to visualize the atrial septa. Similarly, suprasternal view to check for the aorta. So these are all some of the modalities of Doppler echo. I think most of you know that once you start practicing, it will be a little bit handy. And I do see like a lot of the echoes are being done by physician assistant and echo technologists. I think it's a very easy. Once you start practicing it, it will come easy. So this is a very important investigation. All the patients in ICU, they need this echocardiogram to be done to assess the cardiac function. So next I take you to the CT brain. So CT brain, I confine myself to only the vascular conditions, that is stroke, okay? So very simple thing. So the hemorrhage will look like as seen as a hyperdense lesion. So that is hemorrhage in CT scan. In fact, will appear hypodense, that is darker. So I'll show you some of the things. The importance of CT scan is it's one of the sensitive way by which we can find out whether the patient is having a stroke or not. That is the brain. Okay. So this is a patient with right-sided hemiplegia where you could see the little bit darker area on the left side. Okay, that is the left capsuloganglionic region where it could show a hypodense lesion. So this is a very typical thing. So that happens in patients with ischemic stroke. So similarly, I already told you it's a hyperdense lesion. So the hemorrhage. So you could see the hemorrhage here. Okay, so you could see the hemorrhage, intracerebral hemorrhage. So these are all some of the pictures which shows the hematoma here. And this is an extradural hematoma. And this is a subdural hematoma. So my final part of my talk is on ABG. So this is again a very important investigation. All of you should know. So how to do the ABG and how to interpret some basic investigation, basic interpretation. I'll show you in 3 slides. Okay. So the normal values, the pH is 7.3 to 7.45, PCO2 is 35 to 45. PO2 is 80 to 100 and bicarbonate is 22 to 28. So all of you should know this value to interpret ABG. Okay, I'll tell you 2 situations. One is the ventilatory failure where you have the PCO2 is more than 45 millimeters of mercury and you just need to know only one parameter, that is pH. Somebody with a PaCO2 more than 45 with acidic pH, they are having respiratory acidosis. With alkaline pH, they are having a respiratory alkalosis part of it. Similarly, alveolar ventilation. So that is a very important thing, like where you have the common denominator is the PaCO2 that is less than 35 millimeter and depends on the pH, like you see whether the patient is having a respiratory acidosis or alkalosis. So this is in summary, in patients with respiratory acidosis, acidosis means the pH is low, okay? So the pH is low. Whereas in respiratory acidosis, the PaCO2 is high with normal bicarbonate. Suppose if the PaCO2 is low with increase in pH with normal bicarbonate, it's respiratory alkalosis. This is again another condition. The metabolic acidosis and alkalosis, again you have the metabolic acidosis, you have low pH with a normal PaCO2 and decreased bicarbonate, and with metabolic alkalosis, you have elevated bicarbonate with a high pH. Again, commonly done test with all patients with sepsis. All patients in the ICU, they require a BG to be done. Okay, so with this, I stop my talk and I happy to take some questions because it's a very important thing. Like when you receive a patient in a ED, emergency department, like it is very important how to you receive the patients, how to take care of the patients, and how to interpret some of the very basic investigative modalities like ECG, echo, and CT, and ABG part of it. Hope I am clear to you. Happy to take some questions, and thank you.
Thank you, Professor, for your speech. So the floor is open for questions. If you do have any questions, kindly raise your hands and your questions will be addressed. All right, so let us conclude this. Now, before we call on the next speaker, I would like to ask Mrs. Vimla ma'am to please come on stage. So as a token of appreciation and gratitude from our side, we would like Mrs. Vimla ma'am to felicitate our keynote speakers with a small memento. So first, I would like to call on stage Dr. Ashok Kumar Badamali to get a memento from Mrs. Vimla ma'am. Next, I would like to call Professor Dr. Dhananjayan to get a memento from Mrs. Vimala. Next, I would like to invite Dr. K. Lakshmi, another keynote speaker, to on stage to receive a felicitation. Next, I would like to invite Dr. S. Chandrasekhar to get a memento. Next, I invite Dr. Shivakumar to get a memento from Mrs. Vimala. Next, I would like to ask one of our sponsors, Nice Neotech, to get a memento as well. I think as the mementos are given out, it is a short break for everyone here to relax yourselves and gather yourselves as our next speaker is preparing himself and gearing up for his speech. Yes, can we have Nice Neotech on stage, please, to get a memento? Okay, now back to our session. So our next keynote speaker is Mr. R. Shivakumar, President, Indian Association of Physician Assistants, India. Mr. Shivakumar graduated from BITS Pilani, belonging to the 1995 to 98 MPhil batch of physician assistants, and prior to that, BSc degree with specialization in chemistry from Loyola College, Chennai. He has had a long stint in pediatric cardiology in Madras Medical Mission till 2008. He has participated and has been a team leader across many cardiac screening camps across South India during his decade-long clinical career. He has presented papers in scientific conferences and also has been part of academic work of the department. The flair for administration that he has made him do an MBA with specialization in HR from IGNOU, New Delhi. He then took up hospital administration and has worked in leading corporate hospitals for over a decade now. He has worked with the McKinsey team for reducing turnaround time, patient and employee satisfaction, and was instrumental in setting up a stroke institute in Apollo hospitals. In 2013, he took over as the president of Indian Association of Physician Assistants and has been successful in bringing the physician assistants across the country under IAPA. He was a keynote speaker in their conference conducted in Lusaka, Zambia in 2018. He has become the task force lead for curriculum standardization established by the Ministry of Health and Family Welfare, Government of India in 2014, and with effective advocacy has ensured the government recognition in March 2021. So, sir, it is an honor to have you with us, and I invite you to take up the podium. So I see that there is a lot of agitation going on in the audience, right? So I would once again ask you all to please remain silent through the presentation so that we can move on to the further sessions as well. We are asking for your cooperation and for your coordination.
Good afternoon to one and all. I'll make my presentation very short and sweet because it's already 1 o'clock and we are eating into the lunchtime now. So basically, I wanted to deviate a bit from the clinical subjects because, in fact, I was asked to, give a topic on a clinical issue, but then I suggested that I'll deviate because, we need to know something about what is happening and what is expected out of us. Okay, so I took this topic, that is integrating the physician assistant or the associate profession in the Indian healthcare system. So I'll just briefly take you through the genesis of the physician assistant program. This program was started in the United States, basically, by Dr. Eugene Stead in Duke University. The first batch graduated in '67, and then the corpsmen, they became physician assistants. And in recognition of the good work of Dr. Eugene Stead, Physician Assistant Day is being celebrated across the world on the 6th of October. And as far as India is concerned, this program was started by Dr. K.M. Cherian, renowned cardiac surgeon. He was in the University of Alabama working under Dr. Kirkland, and he saw, physician assistants, doing good job there. So seeing that, he wanted to start the same thing. He wanted to replicate that in India. And he was experimenting with the technicians in his institute, that is Madras Medical Mission. But a structured postgraduate diploma program was started in the year 1992. And then slowly he thought, to get brighter minds, we need to have a proper, degree program. So that is when Professor C.V. Ramakrishnan came into the picture. He is a father of, Venkatraman Ramakrishnan, Okay, I'm sure you all must be knowing Venkatraman. He is a Nobel laureate. So Professor Ramakrishnan is his father. So Dr. Cherian teamed up with Professor Ramakrishnan and started a 2-year master's degree program in collaboration with Birla Institute of Technology and Science, Pilani. And slowly, it became a 4-year undergraduate program, 3 years of coursework and 1 year of internship. So that's how it all started. So the physician assistant program, which has a pan-India presence now, started in the year 1992. And it was Dr. Cherian and Professor Ramakrishnan who worked hard for it. So you all need to know that. And as far as the history goes, the first physician assistant in India is Mrs. Gomati Sundar. She was the first person to get that diploma in the year 1994 from Dr. K.M. Cherian. So now slowly we'll move on to the Indian public health delivery system. So this is the delivery system which you all know, and a few statistics I would like to show. This is from the Ministry of Health, which they shared with me prior to the pandemic. So this is India's organized human resource for health. This is something which all of you should know. This is not restricted only to the physician assistants, but also to other healthcare professionals also. So right now, if you see, the numbers are very low, but once we have a council in place, I'm sure more and more people will get registered, and we'll have exact count of how many people are actually practicing in this country. The problem is we have more number of quacks. Normally we say quacks only for doctors, but I would say that there are quacks everywhere. When there are so many people who are working as physician assistants who don't possess the physician assistant degree. Similarly, there are so many people working in healthcare without proper certification. So I am sure all these things will come to an end very soon. And these are certain things which we need to know. Okay, NCDs pose a greater threat, and we actually need more manpower at the ground level to deal with NCDs and certain other issues in the realm of healthcare. And as you all know, the doctor-patient ratio is also on the lower side. I'm sure this can be complemented by physician assistants and other, allied and healthcare professionals. Now, I will briefly take you through the physician assistant's role in healthcare. Now, as of now, if you see, PAs are predominantly working in tertiary care hospitals in major cities across the country. But this is not enough. The purpose of starting any program is not only to cater to the elite section of society, in the major cities and towns. So it has to percolate to the last man in the last village of the country. That should be the aim of starting any program. So today we have more number of programs. See, some 40-50 years back, we probably might have known only doctors, nurses, technicians, and maybe a physiotherapist. But today, there are around 55 to 60, allied and healthcare professions in this country. So why do we need that many number of professions? That is because we need to give good quality of care, which was once done only by a doctor or by a nurse or by a technician or by a physiotherapist. That is not enough. And we need more number of people. So one, the quality. Number two, to reach the unreached. So in the for patients, like, issues like poisoning, snake bite, starting from that to cardiac arrest, seizures, stroke, and heart failure and things like that. And again, you can give counseling for people with, diabetes, medication titrations, avoiding hypoglycemic events, again, systemic hypertension, tuberculosis, bronchial asthma. These are just some examples, which came to my mind. And next important aspect is the National Initiative for Allied Health Sciences. I'm trying to give a 360-degree view. See, basically, I started off with the genesis, then showed you about the public healthcare system in the country, and then spoke about the NCDs and other issues. And slowly now I'm coming to the recognition part. See, certain things, you can aspire to do, but then can you do? You cannot do unless and until the government recognizes your work, unless and until you are licensed to do certain things. So that is when the government of India started off with the initiative called as the National Initiative for Allied and Health Sciences. The first meeting happened on the 26th of June, 2015. And these were the things which were, broadly discussed. And the task force came up with a definition for the physician assistants. In fact, there is a shift. The journey is from assistant to associates. Previously, we were called as physician assistants, and henceforth, we will be addressed as physician associates. So physician associates are healthcare professionals trained in a medical model who practice medicine as part of the healthcare team. They are qualified and competent to perform preventive, diagnostic, and therapeutic services with physician supervision. This was the definition adopted by the task force way back in 2015. And the synopsis of the proceedings, revolved around the curriculum, because once you have a, council, you need to have a standardized, curriculum. Right now, every university has got its own curriculum, its own teaching methodology and training. So that is something which we wanted to avoid. So we wanted to have a uniform, curriculum across the length and breadth of this country. So curriculum, then recognition and licensing of PAs. So without licensing, people are unable to go abroad. So this is not one issue for physician assistants alone. The same thing holds good for other healthcare professionals also. And again, spreading the awareness of the profession. Again, this is something which is applicable for other professions also. Since I am heading the physician assistant profession, I am always mentioning the word PA here, but most of the things are applicable to other allied and healthcare professions also. And for any profession to succeed, you need to have a strong professional body or an association. So we started off with this association in the year 1998, that is Indian Association of Physician Assistants, in the year 1998, headquartered at Madras Medical Mission, Chennai. And that's about the vision and mission of the association. And we had an aim, that we will discuss about the latest developments in the field by way of conducting conferences, publish newsletters, but then we are in the process of coming up with journal also. Very soon we'll be coming up with a journal, and again establish a council and register all the PAs and establish link with medical and healthcare associations worldwide. So what did we do? See, the journey started in 1998 and it's almost 23 years now. So we conducted conferences, we conducted workshops. And when I say workshops, what we need to understand is that there are two important things. One is knowledge, the other component is skill. We normally, learn few things during the course of our study, 3 years or 4 years or whatever it is. But what happens to the skill? There is unfortunately a knowledge skill mismatch. You have knowledge, you don't have skill. So effectively, you will not be able to deliver what you are expected to deliver unless and until you have the skill. So workshops play a very important role in enhancing your skill. And of course, if you attend conferences, if you genuinely attend conferences and not talk like the lords of the last bench over there, I'm sure you will gain knowledge. So knowledge and skill are two important pillars. Okay, if you don't have knowledge and skill, you will not succeed. Next important thing is the certification examination. We actually collaborated with the Indian Association of Cardiothoracic Surgeons and requested them to certify the CVTS PS, that is those who are working in the cardiac surgery department. So, and during the course of our work, we thought we should also take care of students. So we actually converted a one-day conference into a two-day conference, and then we started, taking care of our students. So we have a separate student session in our conference, and during the pandemic, we also conducted webinars. We had eminent people like Dr. Srinath Reddy. We had Professor Bala Guruswamy and Ms. Kavita Narayan from the Ministry of Health, Technical Advisor in Ministry of Health. So these are some of the webinars which we conducted and much more. And the other important thing is advocacy. So we did meet up with the Union Health Minister. We had a discussion with the Parliamentary Standing Committee on Health, bureaucrats, academicians, and public health experts. That is how things move. It's not that easy to get a profession recognized by the government. So advocacy plays a very important role. So meet up with leaders and then get support from professional bodies the world over. And then we also come up with magazines every year during our conference. It's called as the Physician Assistant Generating Excellence. That's called as PAGE. And this is about the international collaboration, which I spoke to you about some time back. So our association is tied up with a lot of professional associations the world over. But the other important thing which we realized was that, that many people who complete the course, because of non-availability of recognition, they felt that, that it's time to move out of the profession. They slowly moved out of the PA profession. At least 50 to 60% of the people who graduated, they are not working in the clinical side. So that's when we thought that we should recognize, good work of the physician assistants. And we slowly started off with some awards like the best PA award, emerging PA award, the PA educator award. And then, once we started off with this, we actually got offers from a couple of people. They said, I will sponsor money. You please, give a best cardiac surgery PA award or a lifetime achievement award. Such things happened. So this is a motivation people to be in the field. The government has just recognized the profession. For the last 25 years, it has been unrecognized, unregulated, and people were disheartened and they slowly started leaving the profession. So this acted as a boon, and then slowly people thought that, that we are being recognized. So these are some pictures of 2019. The conference was conducted in Bombay, Kokila Hospital in Bombay. So you can see people receiving awards. And the next important area is, last 2 years, as you all know, we were suffering from the COVID pandemic. The whole world came to a standstill. Physician assistants, like any other allied or healthcare professionals, did a fabulous job, though unnoticed, unrecognized by the mainstream media. So I would like to, highlight the good work done by our people in the fever clinic, in the ICUs, and in the wards, and even some of our guys did a fabulous job, in theater, because these guys do a coordinating work. They're part of the transplant team. So they ensured that organ transplant did not suffer during COVID. That happened like how it would happen on a normal day. And students also did not keep quiet. They also participated. They were in the vaccination drive. They were also training other healthcare students and interns. They were posted in fever clinic, OPD wards, and the ICU. And these were certain things which we did in public interest. E-flyers, which we actually had posted in the social media to educate the general public about the do's and don'ts during the COVID time. For future initiatives, we are planning to work with government and other institutions, because most of the universities across the country have a bachelor's degree only right now, with the exception of 2 or 3 universities where there is a scope to do a master's and a PhD. So we are working with them to ensure that that our people do a master's degree and then go ahead and do a PhD as well if they are interested. And next year we are planning to launch the Indian Physician Assistant Journal also, because many physician assistants are engaged in research work these days, and we badly need a journal. So we thought we'll start it soon. So next year we'll be starting a journal, and we are also trying to collaborate with some international institutions to give a fellowship program to deserving physician assistants. And this is very important, because this is the National Commission for Allied and Healthcare Professionals Act 2021. So if you see, this is something which play as a repercussion across the spectrum. Okay, so I request all of you to listen. Please don't talk. Please don't talk. Listen. This is your future. Okay. This is the Gazette notification of the National Commission for Allied and Healthcare Professions. So right now, you are not recognized by the government. Now you are a recognized profession. Whichever profession you might be in, not necessarily a physician assistant, even if you are a neurologist or that matter, any other healthcare profession. So on the 28th of March 2021, the Gazette notification has been issued, and if you can go through it, they have defined who a allied healthcare professional is and who a healthcare professional is. So I request all of you to Google this and go through the act. It will be very useful. And again, they have recognized 10 categories, and physician associates are in the 9th category, and the code is 3256. Similarly, all the professions have been identified, and they have coded all the major professions. So it's good time for all of us. We struggled without recognition, and now you are being recognized. Once you are recognized, your pay scales will improve, and you will get an opportunity to go abroad. Because without license, I know many students, many PAs are unable to go and work in Gulf countries. So now you will have the opportunity to go abroad and work, which means you will get greater international exposure, and you will get a handsome package also. So that is why I requested all of you to listen patiently to this. You can talk after another 5 minutes. So just listen for the next 5 minutes. And this is the Gazette notification of the Interim Commission put up on the 21st of September 2021. So which means just like how you have a National Medical Commission, you also have a National Commission for Allied and Healthcare Professionals, and the Interim Commission is in place. This commission will work for the next 3 years, and after 3 years we will have a full-fledged commission. So the commission will work on the regulation of various professions, number 1, and standardization of the curriculum, number 2, and the most important thing for professionals is the licensing. So the commission also will work on the licensing part. So once you have this license, I'm sure many of you can fly. But then remember 2 things: without knowledge and skill, you will not be welcomed anywhere. So please ensure that you possess adequate knowledge and skill before planning to go abroad. Now, before I close, I would like to emphasize on a very important point. So why have I provided the photographs of some, astronomers or, philosophers or Ayurvedic physician? See, these people, they lived at least, Vivekananda, we all know, lived some 100 years back. But other people whom I have indicated here, they have lived at least some 500 to 1,000 years or back, or even more than that. But still we remember them. Why? They are not film personalities. They were not rich people. They never had muscle power. But still we remember them. It's because of their knowledge and skill. So I'm repeatedly telling all of you, irrespective of which healthcare profession you may belong to, please remember that without knowledge and skill, you will never be respected. And thank you for the time. And before I leave, I would like to play a small video. This is an invitation for all the healthcare professionals to attend our next annual conference in New Delhi. This is between the 16th and 18th of September. At least I'm happy that I could make all of you to be quiet for 40 seconds. I think that's my success. Thank you.
Thank you, sir, for your speech. So on that note, we will be having a break for lunch now. Before you, I would like to tell you about the sequence for lunching. So before breaking for it, I would like to tell you that the side door would be closed. So please access through the main door. And as a request, I would like to ask the Vijaya College students to stay back in the auditorium. And the first slot would be the Savita College and the Apollo College students. Kindly please use the main door and you can go in a line to the lunch, which is happening at the dining hall. So yes, it is the first slot is the Savita College as well as the Apollo. Hello. Hello. Hello.
यार ऑडियो ज्वाइन किया मैंने पर फिर भी नहीं आ रही आवाज। डिस्कनेक्ट ऑडियो का ऑप्शन भी आ रहा है यानी कनेक्टेड तो है ही। मैंने किया लीव करके कुछ भी किया।
have to stop the session also, but this is what we agree on. Okay? Okay? If you're okay and you agree to this, please clap your hands. Okay, thank you. Now that we are on the same page, okay? Once again, any noise or any disturbance you want to chat, kindly please excuse yourself. You can go out and chat if you want to. But inside here, please maintain the decorum. Please maintain silence. Okay? If not, as I said, everyone has to raise their hands. Thank God we've agreed on that. Before we start this session, I have a few rules and guidelines I would like to tell all the presenters here. Just a gentle reminder. So each of your presentations, you will be having a time limit of 8 to 10 minutes. So kindly keep your presentations under that. We do have a lot of presentations happening today. With respect to our session shares time as well as to other people's time, we are asking you to keep your presentations under 8 to 10 minutes. Kindly do not exceed this. If you do, we will be forced to step in and stop you at that point. So I'm giving the session chair also the permission for that. And this next guideline is when you're putting up your presentations over here, right? I will be calling the first presenter and also the second presenter. The first presenter would kindly come and sit here, and the second presenter could also sit in the second row. The second presenter, kindly give your content to the tech team here so they can keep your content ready for the next presentation. Once again, the second person who's going to be presenting, kindly give your content to the tech person so that they can keep your presentations ready. This is done so that we can save time. As the students are pouring in, please settle down fast. As each presenter has done with their presentation, the session chair would be asking them any questions or any doubts that they have. So we will be spending about 2 to 3 minutes on any questions that the session chair has on the presentation. So kindly prepare yourselves for that. Students in the last, settle down. Girls. Yeah. Students, girls in the middle, the plated girls, please sit down.
If you're using a mic, it's going to be a speaker.
So I would like to welcome our session chair, Dr. Pooja Mahaseth of the MGM School of Physiotherapy to chair the session and preside over this. So ma'am, we welcome you to our conference. Thank you so much for honoring us with your presence. So I would like to announce the first presenter and the following presenter. Kindly seat yourselves in the front rows so that you can be ready with your presentation. So the first presenter is Mrs. D. Janupriya. Could I please have you? And I hope your presentation is ready. And the second presenter is Mrs. Sindhuja Vinod. I request you to provide your content to the tech team so that your presentation is ready. As we move forward, I'll announce the required people according to the order that we have. All right. Okay, girls to my right side, please settle down. Okay, thank you. So I'm handing over the mic to ma'am.
So this one you.
So good afternoon, all are present here. So I am D. Janapriya, representing Vijaya College of Nursing. So I thank this opportunity to my principal and vice principal for this wonderful podium for presenting in an international conference. So straight away moving on to my presentation. So as you all know, reproductive and child health was launched in the year of 2005. Even with that launch, we had a lot of problem, especially in the maternal mortality as well as the neonatal mortality and infant mortality. So the government has changed the RCH into RMNCH plus A. So it is reproductive, maternal, neonatal, child health plus adolescence. So we need to give more concentration on adolescence. Whatever the concentration we are giving for the reproductive and child health, same the effectiveness should be there for the age group of adolescents. So in this concept, so in 2017, they are renamed into RMNCH plus A. And even in the adolescence, we were mostly talking about the main problems of nutritional problems, other behavioral problems. The iceberg phenomena of usage of tobacco is very less. So in our country, when you see the statistics, as per Udaya study, which was conducted in the 2010, around 20% of boys in the age group of 15 to 19 is consuming alcohol. In the same way, 22% of adolescents in the Uttar Pradesh is consuming tobacco and tobacco products most widely. So there is a need where we have to start the tobacco consumption abuse prevention program in the early onset itself. So we were thinking tobacco consumption prevention should be start in the adult age group, but when you see the onset, it is very near in the 12 age or even in the 13 years, the children are start using consumption of tobacco or any other tobacco products. So in another study, when you see 46.36% of slum-dwelling adolescents are using both smokeless and smoking tobacco in addition to alcohol and cannabis. So we need to start some amount of intervention program in the aspect of preventing the tobacco abuse among the adolescents. As per RMNCHA matrix, when you see the 5x5 matrix in adolescents, we have to go with the community-based intervention program. So when we are talking about the prevention, it should not be a institutionalized prevention or it should not be a hospitalized prevention. It should be in the form of community-based intervention program. By taking into consideration, the researcher has taken the study to assess the effectiveness of the community-based intervention program on knowledge and attitude regarding the health effects of selected substance abuse among adolescents in selected area at Kanchipuram districts. So the main objectives of the studies are to assess the pre-test and post-test level of knowledge and attitude among the adolescents, to find out the effectiveness of the community-based intervention program, and to associate the post-test level of knowledge and attitude regarding the health effects of selected substance abuse among adolescents with the selected demographic variables. So when coming to the operational definitions, here the effectiveness means that package which we are giving the community-based intervention program. And what I mean by community-based intervention program? Here the scholar has taken as a group of activities like video-assisted teaching on health effects of selected substance abuse, nicotine replacement therapy and smoking cessation program for 45 minutes, a self-instruction booklet on skill for adolescents, promoting alternative thinking strategies and guided goals and psychodrama. In the last aspect is psychodrama on a life skill training program for social adjustment for 45 minutes. So here the knowledge defined correct written response from the adolescents. Attitude is here the attitude is assessed by using 5-point Likert scale. Here the health effects of selected substance abuse refers to the physical, psychological effects of selected substance abuse like cigarette or smokeless tobacco consumed by the adolescents. Here the researcher only has taken the substance abuses of cigarette and smokeless tobacco. Here adolescents refers to the adolescents, those who are in the 14 to 19 years, those who are working in the construction site and who are all having the abuse of cigarette and smokeless tobacco in the area of Kanchipuram districts. So the hypothesis is the researcher formulated there is a significant difference in the pre-test and post-test level of knowledge and attitude of the health effects of selected substance abuse after the community-based intervention program. And there is a significant association between the post-test level of knowledge and attitude on health effects of selected substance abuse with the selected demographic variables. So the review of literatures in the part 1 containing 3 subtopics of review of literature to prevalence as well as the health effects, and third one is effects of selected substance abuse, and the researcher used the health promotion behavioral model for the conceptual framework. And coming to the research methodology, here I have used quantitative research approach, and research design is pre-experimental, one group pre-test post-test method. So here independent variable refers to the community-based intervention program, and dependent variable refers to knowledge and attitude regarding the health effects of selected substance abuse. So the research setting is conducted in 2 construction sites. One is at Sungasatra, another one is at Sri Perumadur. So here the target population is adolescent, and accessible population, those adolescents which the investigator can assess. And sample adolescents who were fulfilling the inclusion criteria, and I have taken 30 samples of adolescent with the inclusion criteria of, I have taken both boys and girls between the 14 to 18. Already those who are in using the cigarette and smokeless tobacco, and those who are available during my study, and those who are willing to participate. And exclusion criteria, those who are already undergoing any intervention program for tobacco, and those who are not able to read and write in Tamil. And data collection period, the first part containing demographic variables, and second part containing the knowledge assessment structured question, which is having 25 multiple choice with the interpretation of adequate knowledge, moderately adequate knowledge, and inadequate knowledge. And part 3 containing the Likert scale, attitude scale. Here 12 positive statements and 13 negative statements. So with the options from strong agree to strongly disagree. So for negative statements, the scoring will be in a vice versa. So the score interpretation is unfavorable attitude, and moderately favorable attitude, and favorable attitude. So last part of the my study, that is the intervention program. It started by getting the informed consent, and first visit they have to go with the video assisted teaching, followed by the structured teaching program. In the second visit, I will be giving the self-instruction module, which is constructing all the point of skill for adolescent, promoting alternative thinking strategy, guided goal choice, and last visit they have to undergo psychodrama, followed by the post-test. So the validity of the tool was done by the experts in nursing, and reliability of the tool is 0.85 and 0.82, which is reliable in nature. And pilot study, I was conducted the pilot study in the Kumananjavadi area, and data collection. So as per the schedule, so I have done the first I have selected the samples, then informed the consent, and every day 5 to 5 samples has been selected. And as my community-based intervention program has been given for 4 different settings for the participants with the pre-test, and last I have conducted the post-test. So when you go to the data analysis, section A is a frequency percentage distribution of demographic data of the adolescent. Section B, frequency and percentage distribution of pre-test level of knowledge. Section C, frequency and percentage distribution of post-test level of the knowledge. And section D, frequency and percentage distribution of pre-test level of attitude. And section E, frequency and percentage distribution of post-test level of attitude. And section F, comparison of mean and standard deviation between the pre and post-test level of knowledge. And section G, comparison of mean and standard deviation of the attitude level. And section H, association of post-test level of knowledge with the demographic variable. Section I, association of post-test level of knowledge with the demographic variable. And discussion part. So when you see the graph, you can able to understand. My first objective was to assess the pre-test and post-test level of knowledge. In the pre-test, it is the 70% of adolescents not having adequate knowledge about tobacco product and their ill effects. So after the post-test, the knowledge level has been gained into 73.3%. The same way attitude in the pre-test, 73.3% having inadequate attitude related to health effects of selected substance abuse. In the post-test, it has the favorable attitude has been shown by the adolescents about 76.7%. In the same way, second objective of find out the effectiveness of community-based intervention program. regarding the knowledge and attitude level. So in the pre-test, the mean level is 10.5. So after the intervention, the post level is, the mean has been increased from 10.5 to 19.17. Same way standard deviation from 4.12, it has been decreased into 3.06. And the t-test value is 26.69, which is highly reliable to p less than 0.01. So same way for attitude from 42.63, the mean has been increased to 76.4. Same way the standard deviation 8.52 to decreased into 5.44. The test level is 21.92, which is highly significant in p less than 0.001. So in the third objectives of the selected demographic variables along with the...
Januma, it's over 10 minutes.
Okay, so that's all.
Thank you.
So at the end, when you give a community-based intervention program with the peer group, it is very useful for, instead of going for institutional-based intervention programs. That's what's the conclusion of the... Thank you for this opportunity. So another thing.
Thank you for the presentation. Next. I wanted to see the conclusion. What was the conclusion you said?
So when you go for a community-based intervention program, so we can able to modify the behavior of the adolescents. So as per the RMNCHA, so instead of going for an institutional-based program or based training to the adolescents, this will influence on the behavior of the adolescents. So when you go with the adolescents, with the peer group or the caregiver or with the guardian, so with the same setup, it will be very useful. And I have taken as a psychodrama, so where the participant will make themselves as a participant, so they will enact. So with that, they have come to the conclusion that when you go with the tobacco products, it will come as a ill effect to them. So most of the people has agreed and they have started consuming in less effect.
What was the significance difference? Pre and post.
So the mean has been decreased. I have shown shall I show the graph again? So it has been from, so before that 73% having inadequate knowledge. After my intervention, about 76% have gained knowledge regarding the ill effects of substance abuse. Same way in attitude from 73 unfavorable into 76% favorable.
Okay, very good. So as our next presenter is getting ready, I'm sorry, but in the back, I heard a few voices and I saw a few faces talking. So I'm sorry, we have to resort to our exercise, So kindly, all the presenters back, right, of this row, okay? All the presenters, all the audience students who are sitting, kindly please raise your hands as we had practiced in the start of the session. Yes, I'm not joking, I'm not kidding. Please raise your hands. Both your hands, please. Yes, everyone, all your students, yes. Yeah, straight. Yeah. Just raise it straight. Yeah, this row is fine. This row is good. Perfect. Clap for yourself, this row. Yeah, thank you. Please put down your hands. So let me call on the next presenter that we have is Mrs. Sindhuja Vinod. So she'll be giving an oral presentation. And next, I would like to ask Mrs. Pearl Priyadarshini to be ready with her presentation with our tech team.
Yeah, good afternoon, everyone. It's my pleasure to be here standing in front of you. I would like to thank the first Society for Nursing Practice and Vijaya Educational Academy for giving me such a huge opportunity and give me this podium to present the review article. So I have chosen the artificial intelligence care because this is very, very interesting, and in this current scenario it is very apt, and day by day in daily uses every one of us using without knowing. Okay, let's move on to the introduction without any delay. So today we are going to discuss about the introduction, The content which we are discussing is timeline, types of artificial intelligence, and why do we need in healthcare, domains of artificial intelligence, and the future, how it will be. So the introduction of artificial intelligence. What is artificial intelligence? So in today's scenario, it is very, very important. Artificial intelligence in healthcare is an overarching term used to describe the use of machine learning algorithms and software or AI to mimic the human cognition in the analysis, interpretation, presentation, comprehension of complex medical and healthcare data. So what is artificial intelligence? So intelligence plus artificial together, it makes artificial intelligence. Artificial intelligence is a simulation of human intelligence by machines. The ability to solve problem, the ability to act rationally, the ability to act like human. So now we are going to discuss about the timeline of the artificial intelligence. So in 1955, John McCarthy coins the term artificial intelligence. In 1960 to 1970 period, produced first problem-solving program known as dental assisting to identify the bacteria and recommending antibiotics. In the year 1980 to 1990, artificial intelligence system in healthcare was designed to accommodate the absence of perfect data and built on the expertise of physicians. In the year 2010 to 2019, AI in electronic health record system and robotic assisted surgeries, etc. developed. In the year 2019 onwards, preclinical research and personalized healthcare was started. So now we are going to see about the types of artificial intelligence. We have three types. The first type is artificial narrow intelligence. Second one is artificial general intelligence. Third one is artificial super intelligence. The first type is artificial narrow intelligence. So this is also referred to as weak intelligence. It is a one type of artificial intelligence we have successfully realized to up to date. Narrow artificial intelligence is a goal-oriented, designed to perform singular tasks. Examples: face recognition, speech recognition, voice assistance, driving a car, searching the internet, and is very intelligent at completing the specific tasks in the program. So the example for narrow intelligence, you might have heard Alexa, right? So this is the best example for narrow artificial intelligence. So next is a general and strong intelligence. So strong artificial intelligence, or it is known as deep artificial intelligence, is a concept of a machine with general intelligence that mimics exactly like human intelligence. And it think, understand, and act in a way that is indistinguishable from that of human in any given situation. So this example for strong super intelligence is science pictures. That is example for in India, we have Tamil Nadu director Shankar has produced film Endiran, and recently we have seen Google Kutappa. Everything is a super intelligence. Super artificial intelligence is the best example I can give you. So this is a super intelligence. Artificial super intelligence is a hypothetical artificial intelligence that doesn't just mimic or understand the human intelligence. So it is not only mimicking what the human does, it does more than that. Okay, artificial super intelligence is where machines become self-aware and surpass the capacity of human intelligence and ability. So why do we need artificial intelligence in the healthcare? To save time, energy, money, to avoid unnecessary walk to the hospital for minor ailments, to avoid excessive physical burden, to use e-referral system connects these peripheral hospital with tertiary level hospital. So now we are going to see the domains of artificial intelligence and also the newer technologies which is available in today's scenario. The first one is machine learning, neural networks, robotics assisted surgeries, expert system, physiologic, natural language processing. So first one is natural language generation. So this is the example for natural language generation, which converts the data from, converts the normal data into the machine language. So machine process and communicate the different ways than the human brain. Natural language generation is a trendy technology that converts structured data into native language. So the next one is speech recognition. This is also one of the domain of the artificial intelligence. So this is the example. So speech recognition is another important subset of artificial intelligence that converts human speech into the useful and understandable format by the computers. So next one is a strong decision making. So decision management helps in making quick decisions without any delay during the emergency situations. So in that way, artificial intelligence is very useful. Next one is biometrics. Deep learning, another branch of artificial intelligence. Actually, deep learning, don't confuse artificial intelligence with the deep learning. It is a subset of artificial intelligence. So deep learning, it is another branch of artificial intelligence that functions based on the neural networks. Neural networks is nothing but structured. Multiple neurons together, it will form the deep learning. So this technique teaches computer and machines to learn by example, just the way human does. So this is the machine learning. Machine learning is also another subset of artificial intelligence. Machine learning is a division of artificial intelligence which empower machines to make a sense from data sets without being actually programmed prevention. So next is a robotic process automation. This is very, very important. Robotic process automation is an application of artificial intelligence that configures a robot. A software will be applied to interpret, communicate, and analyze the data. This discipline of artificial intelligence helps to automate partially or fully manual operations that are repetitive and rule-based. Peer-to-peer network. So the peer-to-peer network helps to connect different systems and computers for sharing data without transmitting via server. So this is the virtual agent. Now virtual nursing assistant is also available. This is the latest technique of artificial intelligence. So this is one of the example. Virtual agent have become valuable tool for instructional designer. A virtual agent is a computer application that interact with humans. Web and mobile applications provide chat box as a customer service agents to interact with human to answer the queries. So next is, this is the hardware which is used for the artificial intelligence. Artificial intelligence in the healthcare, past, present, and the future. There are many studies. It's released. Recent studies have shown, and this is, I want to tell you, this is the recent day-to-day life without knowing, and we are using all this artificial intelligence like Google, example, Siri is the best example for narrow, super, and general artificial intelligence. Google, Alexa, Alexa is a narrow artificial intelligence, Messenger, WhatsApp, Hello, Telegram, Twitter, Line, and Skype. All these are the daily basis used artificial intelligence without our knowledge. So pros and cons of using artificial intelligence. So first we are going to discuss about the pros: better data-driven decision, increased disease diagnosis efficiency, treatment cut time in half, integration of information, reduce unnecessary hospital visit, create time saving, administrative duties. So there will be a cons. Concern regarding privacy and security, lack of accurate healthcare data will be the major cons here. High initial interoperability and potential for increased unemployment in future might be the con. So the future of artificial intelligence. So by 2020, we can expect artificial intelligence will access multiple sources of data to reveal patterns in disease and aid in treatment and care. Healthcare system will be able to predict an individual risk of certain diseases and suggest preventive measures. Artificial intelligence will help reduce waiting time for the patient and improve efficiency in the hospital and health systems. So conclusion, perhaps most of all, I believe we must keep in mind that artificial intelligence most powerful use is to enhance human capability, not to replace them. The heart of connected care is in new technology. It's people, the people who need to be cared for and the people who work so tireless to deliver it to all of us. So there is a small video. So in this, we can see all the domains of the artificial intelligence. So in this, we can see the face recognition, so voice commanding, everything it is, you can see. Thank you. Thanks for the opportunity.
So session chair, do you have any questions that you would like to ask
No,
her?
no.
Okay. So moving on, next I would like to invite Mrs. Pearl Priyadashini to give her presentation on blended learning, a boon for the healthcare professionals. Next, I would like to invite Dr. Gajalakshmi to keep her presentation ready with the tech team. Dr. Gajalakshmi.
A very warm good afternoon to one and all gathered here. It's my privilege to be a part of this conference. And myself, Pearl Priyadashini, Professor, Vijaya Educational Academy. And everyone is awake, sleeping, I think, and I guess you could listen for some little time. And okay, my topic is about blended learning. So what is blender? Have you heard about the term blender? Blender. So mommy does so much of dishes for us, right? Like she uses mixie and blender to put all the various ingredients and she gives us some good food, right? So blended is like many things come together. So today my topic is going to be on blended learning. So let us see about blended learning. So what is blended learning? So today, now you're sitting in this place and you're learning now, right? So this is also an example of blended learning. So blended learning is also known as hybrid learning, is an approach to education that combines online educational materials and opportunities for interaction online with traditional based classroom methods. So it requires a physical presence of both teacher and the student. So this 2 years, I think you would have been more upgraded in technology. Yes. So how did you upgrade yourself? Always in a mobile phone. And online classes were extra added advantage for you to be all the time on the phone. Am I right or wrong? So you would have been like nearly would have been competitive to a IT professional. So blended learning here. So the history. So I just don't want to tell all these things, like how the computer was made and all the programs came and the knowledge got updated and a lot of technological methods came and all. And now we are doing all the learning methods, a lot of programs in virtual. Like a teacher doesn't only require a classroom to teach the students, right? So they also require the PowerPoint presentations, projectors, and virtual meet, the Google Meet. So in online classes, what did you do? You were learning through your teachers, right? How did you learn? You learn by your own, but teachers were there to support you, right? So that is called blended learning. So types of blended learning: face-to-face driver, rotation, flex, lab, self-blended, online driver. So sometimes if teacher asks you any doubt and you don't get it, like what we will say, go and refer the Google. So those days it was not like that. We have to go and refer a book. So now it has become everything easy for you. So you can go, you can learn notes, you can take notes, you can see the pictures, you can see even videos of surgeries and all through blended learning. So first, so here face-to-face driver is where the teacher drives the instruction. You are familiar with this thing, I guess so, because in most of the online classes, the teacher will be seeing you face-to-face. So what you guys will do, you will put in mute and tell, you will never answer the questions, yes? Because we all face the same situation. So what you will do, you will put in the mute and tell, you will never even respond to us. Okay, so, but in online classes also, you'll be having the teacher's presence there. So that is where the teacher drives the instruction. And even a struggling student, they can have even classes like one-to-one approach. The teacher even can teach the students in online, and she can also recognize the poor students, and she can also interact in a better way. So this student may access the extra help to the classroom, and it allows for a traditional classroom experience. So when we only hear the teacher, we may not listen for a longer time. But when you see a teacher, they can also use the board, and through that you can see, and they can share some videos in the middle. They can share some notes in the middle. You can take it, and some PowerPoint presentations makes you learn more in a better way. So to use a blended learning classroom, you must identify the students who need supplemental instructions, find time to use a tool, choose the appropriate digital tool. So blended learning requires a little extra effort of technological support, because initially you didn't know how to access the website and all. Yes, when we share a link, in the initial phases I'm talking about, you'll be struggling to, I didn't connect, ma'am, please allow me, ma'am. So I see some students telling, ma'am, please let me in, ma'am, I'm not able to connect, this Wi-Fi is not supporting, error is coming. So initially you have to learn the technology things, but once you learn all the technology things, you can do your assignments of your own, and wherever your free time, you can do some home mock test, classroom test, and everything and all. So rotation model, the teacher gives you some rotation model, like focuses on using learning stations. Like example, when you play a game, right, they will tell, okay, good, you jumped there, okay, good. It will give you some comments. The same way, when you finish a task, the student, the application will tell you, okay, good, then after that you can skip there. So it has made easy for the teachers also, and it does also, you guys like to be on the phone, right, use a computer for games and all. So through that, you can learn many things. So flex model, lot of same thing, flex models, the curriculum will be turned into the learning process, lot of pictures, lot of videos, then a consultation. See, nowadays doctors also know how they are doing the consultation. How they doing? For small minor ailments, are we running to the hospital? No, right? We are doing online consultation. So that is one of the thing. And learning, in blended learning, you can see the surgeries in a live manner. When we studied, we have to go to the operation theater and have a look at the surgeries, and there'll be a large crowd and we'll be peeping. But now it's not like that. The live surgery is displayed in a LCD projector or LED projector, and a large group can see. So that is one of the plus point in blended learning. So again, then online lab model. How many of you have been to lab? Can you see what are the labs are available? No. You've never been to lab at all. Okay, anatomy lab, biochemistry lab. So you can see a lot of specimens and a lot of things in the lab. It's same way. When you want to see more articles in the lab or more procedures in the lab, you can see it virtually also. So blended learning is very much effective for a larger group. So in one classroom, or 50 or 100 students only can accommodate, right? In blended learning, through the virtual process, more groups of people can connect and see how the teacher teaches, and you can learn a lot of topics and all. And self-blended model, self-blended self-assessment tool. Have you seen the children doing now in a better way? The school, they're giving self-assessment. Yes, when it is like a homework for them. So what will happen? Self-assessment tool, when they do in a correct manner, they will give +1 mark. If they do it wrongly, -1 mark. They'll appreciate. Yes, go on. When you complete it only, you will be able to go to the next assignment. Okay. So in blended learning, it is made easy for the students to do the homework. So those time, what we used to do, we have to open the book and write pages into pages. Now everything is up already, is there in the system, and you have to just tick it, or you have to press a button, and it is very easy for you guys to learn. So online driver, we give you notes in the online, we share the presentation, we give you notes through the online. Whatever we take the class, what you're telling, ma'am, please share it in the WhatsApp, ma'am. So when we tell you to refer in the books, what you guys are telling, ma'am, please share it in the PowerPoint in the WhatsApp, ma'am, so that it will be easy for us, ma'am. So this is a main advantage. You can have a lot of learning materials. You can have reinforcement. You can relearn again and again. So next is blended learning in healthcare. So here comes the boon of the healthcare. What is boon? The major advantage, okay? As I said here before, the surgery, if at all there is surgery happening, only small group, those days only small group of people can see. But now how much? Even we can see now all through the world, you can get connected, and even doctors or even healthcare professions can connect it. Conference like this, and also tomorrow is going to be a virtual meet, right? So those people will not be able to come here, right? So we are going to do one online. So that is also one advantage. And e-learning, virtual reality, printed text, augmented learning, and classroom teaching. So you will have the feel of classroom teaching also. So hospital life supporting training, simulation, CPR models, ACLS, BCLS, everything can be taught to in blended learning. So people who are not able to attend the class at the particular time, what they can do, they can see in virtuality and they can learn. Even you can do all some tasks and all in this. So today, life balance, see here, blended learning can be particularly helpful to healthcare staff who must fit learning in with their work and life commitments. Online elements can be taken. So those were the days when people had to write a lot of notes. Even the doctors, the nurses, and the healthcare professionals, they'll be writing notes together, okay? But now it's not like that. Everything is, if they have any doubt also, they can, through the system, they can rectify their doubts. So importance of blended learning, the progression in digital methods for education was eminent even before the unpredictable onset. So when did we knew the value of value of technology. So what parents thought, how my son or daughter is going to study, your parents would have also thought, and teachers were worried how we are going to teach. But through this technology, we got this blended learning. It was easy for us to complete our classes, and you also were, you were passed right from first year to second year. All these things happened only through the blended learning, through the help of the virtual technology. So blended learning offers a multitude of real world skills that directly translate into life skills, from research skill, self-learning, self-engagement. Even though like when your teacher says like, gives you an assignment, what you will say, ma'am, tomorrow morning I'll finish it, ma'am. On the online itself, I'll finish and submit, ma'am. All the registration work, all the files work, you're just doing things fast, right? Because of this blended learning only. And advantages of blended learning is collaborative learning experience, virtual cafe. Blended learning increases student engagement. So you all like phone, you like to see the computer, you like to see all this technology, right? So you'll be engaged more time. Even though we take classes in classroom, if we take class, what you're doing, after half an hour, you guys are not listening, right? But in virtual meet, what you're doing, okay, you'll be entire time on the phone listening. At least you'll put at least a mute, at least you'll see the notes or the presentations, what we are making. Okay, then blended learning increases student engagement, gather learner data for better insights. So you can learn a lot of things. Lot of things is like you can see the live surgery, you can see live examples, you can interact with a lot of various departments of healthcare professionals, which is very useful for you and well suited for large groups. See, in one link, you can connect a lot of people, right? Sorry to what are the okay. So coming to the conclusion, blended learning has been a very, very great advantage to the healthcare. Thank you. Thank you.
So if the session chair has no questions, then we will be moving on to the next presenter. So the next presenter is Dr. Gajalakshmi, who will be presenting her work on neuroimmune crosstalk by cerebellum in rats. The next presenter is Ms. Aishwarya from SRM Medical College. Is Ms. Aishwarya here? Please present your content to the tech team and please be ready. So I am handing this over to Ms. Dr. Gajalakshmi.
A very warm good afternoon to one and all present here. I'm going to present my topic on neuroimmune crosstalk by cerebellum in rats. As we all know, Hippocrates, whatever happens in the mind influences the body and vice versa. In fact, mind and body cannot be considered one from another. It is quite impossible to think of a phenomenon so complicated as that of an immune system that could be carried out in an organism without the participation of the central nervous system. It was Spector in 1980 who said that this nervous system being the basic initiator of all these general immune response, and he coined the two terms of neuroimmunogenesis and neuroimmunomodulation. There is a bidirectional communication existing between the neuroendocrine and the immune system, probably through the hypothalamo-pituitary axis, or it could be through the autonomic nerves. So you could see here a tribe getting the blessings from the leader tribe. So this mental health and modulation of immune functions have got a very strong link, which is quite present time immemorial. So we have reported that many regions like cerebral cortex, hypothalamus, hippocampus have participated in neural modulation of immunity. We know the cerebellum, the silent area, or it is called the little brain, has been known for years together for motor coordination. So apart from motor control, the cerebellum do participation in modulation of some non-visceral somatic activities. So the aim of the present study in my original research work is whether the albino rats cerebellar fastigial nucleus electrolytic lesion can modulate the neutrophil functions. So healthy adult male Vristar albino rats were selected for the study after obtaining the ethical committee approval from the institution. The groups were divided into control, bilateral, fastigial nucleus lesioned animals, and bilateral sham operated animals. The sham operated animals are taken into consideration because during the electrolytic procedure, the superficial structures do get distracted. So we want to delineate the effect is purely because of fastigial nucleus lesion and not because of the superficial structures getting distracted. So the procedure was followed according to Pellegrino et al. We used the electrolytic lesion using the stereotaxic apparatus. Rats were anesthetized with pentothal sodium. The ordinates for fastigial nucleus were followed according to the Pellegrino et al. It has been standardized. We have been using 2 ampere at 100 volts for 10 seconds to do the electrolytic lesion. So the parameters studied in this were estimation of plasma corticosterone level, total leukocyte and differential count, neutrophil adherence test, Candida phagocytosis, nitroblue tetrozolium reduction test. These 3 tests are to assess the neutrophil functions. And to substantiate that it is purely because of neutrophil, we wanted to estimate the cytokine, particularly tumor necrosis factor alpha. So the results were analyzed using the SPSS software. Statistical significance were studied using ANOVA, followed by Tukey's multiple comparison test. To confirm the lesion effect, we controlled with the control as well as the sham group, and data were presented with the mean standard deviation. So you could see the lesion, that is the difference between the control and the lesion group. We are using the Crescel fast violet staining to show the nucleus lesioned animals. So in this, you can see the bilateral lesion animals. There is a significant increase in the corticosterone level when compared with sham and control level. So this is quite in agreement with the Ghoshal et al. In 1998, because increase in glucocorticoids probably led to decrease in the total leukocyte count. As you can see, it is observed in my study, as well as an inverse relation observed in lymphocyte and neutrophil count also. So you can see the neutrophil adherence test. As we all know that in neutrophil, one of the main steps performing its function is adherence. So there is a decrease in the adherence in the lesioned animals when compared with the other. So this could be because the binding avidity of this neutrophil selectin is upregulated by these factors. One such factor is tumor necrosis factor alpha, and that you can see in bilateral lesion animal, it is quite reduced when compared with sham and control. So probably because of this TNF alpha, which is reduced in the lesion animal, could be one of the reason for reduction in the neutrophil adherence. So the next is the Candida phagocytosis. So the Candida phagocytosis test, we used to check for PI, the phagocytic index and the avidity index. The PI index is number of Candida in 100 neutrophils, whereas it is the mean particle number. We got significant reduction in the PI index, no such significant change in the AI index. So the next is the nitroblue reduction test. Here we use the nitroblue tetrazolium dye. Reduced in the lesion when compared with the control group.
Where they? Where they?
So probably in our study, what we observed, that is the reduction in the neutrophil function may be due to the disturbance in the HPA axis, probably because of the corticosterone level. So here I would like to explain the possible mechanism behind the fastigial nucleus lesion is, it could have been due to the modulation in the cytokine levels, and that would have brought a decrease in the neutrophil functions. So there is a direct as well as a bidirectional connection between cerebellum and hypothalamus, which was already reported by Haynes and Dietrich. So I would like to suggest that there is a confirmed association between the cerebellum and the modulation in immune system. So always our professors have taught us from bench to the bedside. So where are we going to apply this concept of neuroimmunomodulation? It comes in the cases like cerebellar progressive ataxia, autism, and autoimmune disease. To further understand the pathogenesis and etiology, neuroimmunomodulation is one of the emerging trend in the field of medicine. So these are my references. Thank you.
Would the session chair have any questions for the presenter? Your presentation was ready. No questions. Your presentation was very good. It was a nice. Before calling on the next presenter, who is Miss Aishwarya, I would like to call upon Mr. Ambedkar Suprent.
A very good afternoon to one and all present here. So today I'm going to talk about a case report of a patient with Ramsay-Hunt syndrome, and I'm going to highlight the role of audiological evaluations in this patient. So presenter myself, Aishwarya. I am a research scholar at the Department of Audiology and Speech Language Pathology. So I'll explain what Ramsay-Hunt syndrome is. It is a rare condition that causes neuropathies of the cranial nerves, primarily 7, 8, and 10, which is the facial nerve, the vestibular cochlear nerve, and the vagus nerve. It is also known as herpes zoster oticus, primarily because it is caused by a herpes virus group. It is the Ramsay-Hunt syndrome itself is caused by the reactivation and subsequent replication of the varicella zoster virus. So once the virus enters your body, it causes a period of infection, and it then remains in the human body in a latent phase. And after many years is when the reactivation takes place, and it comes out as the Ramsay-Hunt syndrome. So the virus actually causes the herpetic inflammatory lesions anywhere from the level of a ganglion to that of the dermatose, which is the skin. So the common clinical manifestations that we can see are the peripheral facial palsy, that is nothing but the facial paralysis that we see in the clinics. It can range anywhere from a grade 2 to grade 5. Then we can also see hearing loss, which is accompanied by tinnitus, because the sensory neural hearing loss is almost always sudden. Then there is vertigo, which is mostly the rotatory type and continuous in nature. Then they are characterized by chronic ear pain, majorly due to the vesicular eruptions on the auricular region. Like I mentioned, there will be vesicular eruptions primarily in the auricular region, and it can also extend up to the mucosa of the oropharynx. So what are the common risk factors that causes this reactivation is aging, immunodeficiency, immunosuppression, hematological malignancies that will help the virus transport from one area to the other. Bone marrow and solid organ transplant recipients can also be at risk for reactivation. So because I'm highlighting the audiologist's role in this particular syndrome, I'll be talking about the pathophysiology of the vestibular cochlear symptoms. So varicella zoster virus is a DNA virus that is from the herpes virus group.
It can cause an acute infectious disease, which we have seen as mostly chickenpox in a very young age for most people. And after that period of primary infection, the virus remains in the human body in a latent stage. So what happens is during the active contagious stage, the viral multiplication occurs very profusely in the skin, which is the epithelial cells. So when there is free nerve endings in the skin, it extends into those free nerve endings, and the viral particles are transported to the neural bodies in the ganglion of the corresponding dermatose. So once it transits into the sensory ganglion, it remains in the ganglion and then becomes latent. So many years later, this latent virus is reactivated. And the most common site for this latent virus is the geniculate ganglion of the 7th cranial nerve. And thus we see an inflammation of the facial nerve as corresponding to the geniculate ganglion itself. So at this stage, it breaks the blood and nerve barrier and it transcends into the labyrinth through the dehiscent facial nerve via the internal auditory meatus. So the IAM, the internal auditory meatus, is where there is the vestibular and cochlear nerves. So due to the proximity of the pontillar medullary junction and geniculate ganglion to these two nerves, it starts inflammating the cochlear and vestibular nerves as well. So in the vestibular nerves, there are two branches, the superior and inferior. So the superior is more susceptible because it is closer to the facial nerve branch itself and it has a longer bony canal. So once these nerves are inflamed, you see something like a neuritis, and thus the patient begins to complain of hearing loss and vertigo. So why I am doing a case report on this is, we know that facial nerve is a pretty common disease now, and Ramsay-Hunt syndrome becomes the second most common cause for an atraumatic facial paralysis. So at present, it is also said that the cochlear vestibular symptoms are primarily outweighing even the facial symptoms. So when identified at an early stage, we might be able to intervene faster and probably resolve the disease at a faster stage without causing a nerve damage. So moving on to the case report. So this is of a 37-year-old female who reported with complaints of a right-sided headache, chronic ear pain in the right side, swelling in the infraauricular region, vesicular eruptions primarily in the concha of the ear, deviation of the mouth to the left side, to the opposite side, unable to close the right eye even with maximal efforts. So all of these complaints were on her right side, and these complaints were seen for 10 days before the prior visit. So the patient reported that she had a history of chickenpox at a very young age, but she could not specify what age. And similar symptoms had occurred 2 years back, for which she self-treated and did not visit a hospital. And the current event was very long-lasting and progressive in nature, which made her come to the hospital. So the patient also began to experience a reduced hearing sensitivity with tinnitus. She experienced pain during swallowing and had complaints of voice changes. So a couple of medical investigations were carried out, wherein on physical examination, of course, we found that there was a deviation of the mouth to the left side. So we diagnosed her with grade 5 element facial palsy according to the Brackman-House classification. The otoscopy revealed there were vesicular eruptions in the right concha with infraauricular swelling, which made it very tender. The right tympanic membrane was also bulged. The video laryngoscopy showed mucosal ulceration of the laryngeal surface of the epiglottis. The right arytenoid was also congested and involved in the ulceration. And the right false vocal folds was congested and edematous, which explained the pain that she had. So the normal mobility was observed, because of which she did not have active feeding or swallowing difficulties. So they conducted a motor nerve conduction test. So they found that it was an axonal pattern of neuropathy with a possibility of regeneration to be present.
So CT scan of the neck also showed parotitis, which is right parotid gland was mildly bulkier than the left side. And MRI brain was significantly normal, just the age-related changes with some granulation. So a detailed audiological evaluation was itself carried out. So otoscopic finding, we did not find anything different from the previous except for the discharge in the ear canal to be present. And the pure tone audiometry showed moderately severe mixed hearing loss with a high frequency slope in the right and minimal hearing loss with a high frequency slope in the left. Emittance could not be done in the right ear, obviously because of the inflammation and the vesicular eruptions. The left ear showed a normal tympanogram with reflexes that were present only at 501 kilohertz. So we attempted to do a subjective vestibular evaluation, but the patient had experienced severe bout of giddiness every time we initiated the test. So it was more like a trigger for her. And she had a nausea along with the vertigo attack for more than 30 minutes to 60 minutes. So this was a classical symptom of something like a vestibular neuritis. So we couldn't do a further testing the same day. And we referred the patient back to the ENT where she was diagnosed to have an acute otitis media. So we began with the medical intervention and the patient was diagnosed with Ramsay-Hunt syndrome with a right acute otitis media, right parotitis with right element facial palsy grade 5 and systemic hypertension. So we also got a clearance from the cardiologist that the systemic hypertension is not going to cause any trouble. So we saw the same patient after 2 weeks, wherein we repeated all the tests and we could see that the conductive component due to the acute otitis media had completely resolved. So it was a pure sensory neural hearing loss with high frequency slope at moderate level. Left ear had only a minimal hearing loss, same as the previous testing. Emittance showed that the middle ear pathology had completely resolved. But one finding here was that the reflexes were absent on the right ear. The left ear, again, the ipsilateral reflexes were present at 501 kilohertz. So this is another classical finding when you have a facial nerve paralysis. So this time we could go ahead with the subjective vestibular evaluation. So we started with the GAN sensory organization profile. It is a 7-step protocol. So in this protocol, we include So we did the Romberg test and the CTSIB. So gaze test was a left beating nystagmus, again a classical finding in vestibular neuritis. So the cervical and ocular VEMs also showed that the right side was affected. So management plans were antiviral drug with steroids. And third evaluation showed that all of these symptoms had resolved except for the ocular VEMP that was absent on the right side. So we recommended her to go for a VRT and also continue with the medical treatment and asked her to come back after 3 months for further investigations. So the conclusion is I'm only highlighting the role of an audiologist in this particular syndrome because early identification is very vital so that we can prevent a nerve damage, and a team approach especially in this case with a neurologist, ENT, audiologist, speech language pathology and physiotherapist can be very important in managing the patient. These are my references. Thank you.
Okay, moving on. Our next presenter is Ms. Chitra Ponnu. She'll be doing her presentation on blood inventory management, cross-matching policy with A1, A2, BO, substitution for age-dependent demand. The next presentation, I would like to call upon Ms. Karen Ovia Babu. Ms. Karen Ovia Babu, yeah, please have your presentation ready for the next. Now I invite Ms. Chitra Ponnu to take up this.
Good afternoon, all of you. I am Chitra Ponu. I am doing my research in mathematics. My topic is blood inventory management, cross-matching policy with A1, A2, BO substitution for age-dependent NIBAN under the guidance of Dr. S. Uma Mageshwari, Vellore Institute of Technology, Chennai. Introduction of my presentation is blood is one of the most essential component for human life. In clinical treatment, medicine has made significantly advances, but in clinical treatment, blood and its components plays a significant role. Blood components RBC, platelets, plasma, and YBC, WBC are still a precious resource, but in blood transfusion, RBC plays a major role. That's why my research article focuses on RBC inventory management. Currently, RBC has a maximum shelf life of 42 days. The objective of the blood inventory management is minimizing the total cost, at the same time minimizing the wastages on blood and its components, at the same time the shortages of the blood. How importance of blood inventory management for hospital blood bank? To avoid unnecessary loss, the hospital blood bank can supply the emergency patient within the time period for. That's why the hospital blood bank is very important for the patient to avoid unnecessary loss. At the same time, the transportation is avoided that can minimize the wastages on blood bags that can minimize the inventory cost on both wastages cost and transportation cost. Problem identification. My problem is the patient who come with the demand will be used in the treatment, or some will be used in the chromical treatment, some will be used in the emergency procedure, and some will be used in the elective procedure. But the patient need is depend on the age dependent. That's why I am focusing on age dependent demand. There is already an ABO substitution, but my research focuses on to ABO, A1, A2, BO substitution. The subtype of A1, A2 up to AN and AEL. In North India, recently the donor who identified the type of AEL blood type, so that we need to focus on the research on the subtype of that in India there are 80% people in A1 blood group, and the other 20% people are in anti-A1. That is also known as A1. The frequency of phenomena type is O and go with A to B. The classification of model is ABO substitution is already existed, and the A1, A2, BO substitution is this. In this model, the universal donor O can accept with the O blood type, but the researcher analyze the patient who can donate their organ. A2 blood type person can donate their organ to O type person, so that the universal donor O can accept from the blood to A2 person. So the model can be created, and the new compatibility matrix is formed with 12x12 matrix. This approach is solving using dynamic programming model. The demand can be classified as age dependent and age independent. The patient who come without age independent, the person who go with LIFO policy, that is shown in RB with the remaining shelf life of 14 to 1 days with the same blood type. Otherwise, the patient go with the blood type remaining shelf life of
48 to 14 days with the same blood type. Else, their patient go with the RBC with the shelf life of 48 to 14 days for the compatibility blood type. In this scenario, I am using my A1, A2, BO substitution. The demand can be scheduled, otherwise that can be going into shortage. These are the parameters used in my model. This is my model formulation. This model is solved through the stochastic dynamic programming model. This backlogged function is, this is the backlogged function. This can create the A1, A2, BO substitution. This is the total shortage of blood type, planning the period T. In this case, I am taking the planning time. T is equal to 1 to 7 days. That is 1 week period. Minimum blood shortage is calculated like with this. And this is the minimum blood wastage during the planning period. Conclusion of this model is the proposed A1, A2, BO substitution model minimize the unavailability of rare types of blood while reducing the outtakes of all types of blood. Highlights of this model is inventory management and healthcare both have potentially to improve their quality. The prevention of wastage of rare type of blood is reduced. Substitution is improved for the universal donor. These are the references. Thank you.
Thank you for the presentation. So does the session chair have any questions to pose? Okay. So we would be continuing on with our presentations, and for the second half of the presentation, I would like to invite Dr. K.K. Dhanavendan of NIPMED, Government of India, Family and Welfare. He's also the head of cerebral palsy and also the coordinator and a nodal officer as well to preside over this second half of the scientific session. I would like to call upon Ms. Kiran Ovia Babu for her presentation on exploring the roles and responsibilities of a speech-language pathologist in palliative care, a case study. Next, I would like to invite Mr. Muthukumaran. All right. So moving on, I would like to invite Mrs. Stella J. Kindly please give your presentation to the tech team for be ready. So Ms. Kiran Ovia Babu, please take the stage.
Good afternoon to one and all present here. So the topic of my study today is basically looking at the roles and responsibility of a speech language pathologist referred to as an SLP in palliative care management in India. So I'm going to focus on how a speech language pathologist's role can come into elevating the patient's need during palliative care treatment. So this is one of the first case study that is exploring the roles of speech language pathologists in India. Okay. Speech language pathologists, also known as speech language therapists, are rehabilitation professionals who work in preventing, assessing, diagnosing, and treating speech, language, and communication disorders. Also, they treat individuals with cognitive communication, swallowing disorders in children and adults. So speech language pathologists are a rehabilitation professionals recognized by Rehabilitation Council of India. And this scientific discipline was launched in India for more than 55 years. So the speech language pathologist role can be categorized as a cognitive, they look at cognitive communication disorders, feeding disorders, hearing impairment, fluency, motor speech disorders, social communication, stroke and brain injury. And they also work in various clinical setups like private practices, hospital, NICU, acute care, skilled nursing facilities, and also school. So these are the roles and responsibilities of a speech language pathologist. So if we look at the palliative care can also be referred to as hospice care. So it is an approach that improves the quality of the life of a patient. It can be an adult or a child and their family who are facing problems associated with life-threatening illness, usually a progressive disease. And it prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. So this is palliative care. So usually palliative care is known as the treatment, end of life treatment care. So when a patient is nearing death, the treatment that is given to a patient is known as palliative care or hospice care. So it addresses the suffering of the individual by taking care of the issue that is beyond the physical symptoms also. So let us look how we can incorporate palliative care in patient care. So if we look at the essence of palliative care, it offers a support system to help patients live as actively as possible until their death time after they are diagnosed with a very progressive condition. And palliative care is explicitly recognized under a human right to health. And it should provide through a person-centered and integrated health services, more to do with a multidisciplinary approach of management. So if we look at the role of SLP in palliative care, so Robin Pollens in 2004 was the earliest person who documented the roles of a speech language pathologist in the Journal of Palliative Medicine. Later, Samantha Ekman and Justin Rowe in 2005 also incorporated many other amplification of voice, felicitation of communication by obtaining informed consent, and linking ENT to the palliative care was done in 2005. Rosie Hoxie et al. In 2017 in International Journal of Palliative Care Nursing were the recent people who had actually concised the role of a speech language pathologist in palliative care management. So moving on to the case study. So it is an 85-year-old female who is Tamil speaking. She has a history of diabetes, blood pressure. She had 2 instances of stroke and her whole body had spastic paralysis. So she had difficulty in communication. There was dementia, which was senile type of dementia, which was associated with the spasticity. She has memory loss and she also had swallowing difficulty. The symptoms were progressive and deteriorating, but in a milder phase. So if we look at the first session of a speech language pathologist, the first assessment was looking at the cognitive communication difficulty. So in the first session, she presented a huge symptom of difficulty in expressing and understanding linguistic information. Looking at the motor speech disorder component of the patient had strained, strangulated voice, mono pitch and mono loudness, which was a component of spastic dysarthria. The patient also had delayed laryngeal elevation during swallowing session, and it can be said that she had a oropharyngeal dysphagia. She also had instance of coughing and aspiration. So these were the symptoms observed in the initial session. If we look at the caregiver children, they were having difficulty understanding what could be the management of this patient, and the children and caregiver reported they had stress because of their inability to understand what could be the management to elevate the patient's difficulty and to find the exact need of the patient. So these were documented in the session 1. So looking at the session 2 of a speech therapist, a cognitive communication difficulty, augmentative and alternative communication was introduced. A low-tech augmentative alternative communication where picture pointing was incorporated. And looking at the dysphagia component, texture modification given by Murray et al., chin tuck was carried out, and also elevation at 90 degrees was also carried out for the patient. The patient had a significant improvement in the aspiration difficulties the client was facing before, and it was confident in swallowing and eating even in the first session that was documented. So this was the thing that was done in the session 2. So moving on to the session 3 of speech therapy. So continuing with the cognitive communicative difficulty, AAC was introduced in the second session. Moreover, right now, English words were also introduced right now in a very low tech form, and also letters were attempted at this particular point in time. So the client was very active in pointing and was so happy that his needs were able to be understood, and he was actually able to express his needs using this low tech device. So dysphagia feeding rate at the third session was modified, given by Joyce et al. In 2005. So at the session 4, it was observed that the client had actually attempted to communicate on his own using the low-tech AAC device at home before the session. So in the fourth session, he was really motivated, and he was able to express his spirituality concerns about prayers and God at the end of his life. So he was able to express this only because the speech pathologists were able to give him a platform for him to communicate his needs. And look, he was very satisfied because he was able to communicate that he want to watch TV and to be involved with the family. Before the family consider him to be, he's going to die very soon. So I'm not going to do much about it, but I have to just make sure that he's eating properly. That's it. But right now, his other two needs were met, and it was really motivating for him to actually live a much longer, but live a fulfilled life. So that was very evident in session 4. So at the end of session 4, I was able to observe that there was a conflict of priority that was seen. So if we look at the medical specialists, they focused on the feeding alone. So they said the patient is not able to swallow. So the speech therapist has to augment that by giving a modifying technique for them to help in swallowing. But if you look at the patient concern, it was very different. He wanted to meet his expression needs to be met. And family concern was looking at the suffering. Why is he suffering so much? So a comprehensive counseling was carried out by the speech therapist at the end of the 4th session by understanding the medical, by telling them that there are immediate needs that the medical specialists are going to focus you upon. You need to take care of it, but also the client priority, which will actually increase the quality of the life of the individual. And removing the suffering and not the sufferer is actually the core objective of palliative care. You're elevating the pain of the patient, but not actually hurting the patient. So that is one that was counseled to the patient, parents' family, and they were really happy about it, that their suffering is being elevated one by one. And they were actually motivated to bring other professionals who had who could actually contribute to the person's life. Creating an inclusive environment was actually like introduced to the parents and the children of the client, and increased participation of the involved individual was also made to be observed, and witnessing demonstrative progress. For example, this 4th session was such a good demonstrative progress that was witnessed by the client's family member. So it was really motivating for them to take further speech therapy or further rehabilitation process. Awareness of the reality of the condition was also expressed to them, and the stages in which the deterioration a speech pathologist can involve them, and to elevate their quality of life was also expressed to them. So the conclusion of this case study is actually looking at the key role in speech, language, and communication difficulties that could be held by a speech therapist, and also the role includes palliative patients in a broader range. So the scope of practice usually gives geriatric as one of the scope of practice, but palliative care can also be included in the scope of practice of a speech language pathologist given by RCI. It can be definitely included. Further, so the role of SLT has become broader from the initial study 2004. So initially it was focusing on the swallowing difficulty, while the palliative community was focusing on the elevating the pain of the patient. But later it went to the cognitive and the communication aspects as the palliative community moved into increasing the quality of life of the patient. So we are moving along with the palliative care community, who's actually helping the client to elevating their pain and increasing the quality of life. So focus points of my study in focus point of my study is we can have more individual case studies initially, so we can understand the broader aspect of how an SLP can work in a palliative care setting. Looking at developing a protocol, it can definitely help an SLP in assessing individuals with communication difficulties in a palliative setting. And also training and facilitating, especially spiritual needs, can also be incorporated in speech language pathologist training, so they can exactly assess what is the need of the patient even without waiting for 4 sessions. So that was supported by one of the article given by Support Cancer Care by Bianca Sackmore et al. In 2015. So these are my references. Thank you. Any? Should I give?
That was a good presentation. Dear friends, we are conducting the convergence of on allied health sciences, I guess. The presenter is on stage, and behind you are conducting conference, I guess. Dear friends, please listen. Actually, it is Allied Health Sciences Conference, which is making you international conference. It should be evident. They are attending this conference. Behind the presenter, she or he should be spend more 15 days or 20 days for the presentation itself. One of the presenter who did that rat, the test was conducted on the research oriented. Many of the professors, they presented very good presentation. Please listen carefully. At least you could find something for your better future. Thank you so much.
Thank you, sir. So I think for us as well, I hope everyone takes this as a guideline and do not repeat this. We do not want to treat you like kids, but if that is what it's going to take, then that is how we will treat you going forward. So please do not make us sing to that level. Moving on, next I'm calling Mrs. Stella J to give her presentation on effectiveness of ergonomic interventions on mechanical back pain and functional disability among the staff nurses. Next, I would like to ask Professor Mrs. Bhuvaneshwari D to keep her presentation ready. Good evening to one and all gathered over here. I'd like to thank Principal, Vice Principal of Vijaya Educational Academy and Society for Nursing Practice. So my study is effectiveness of ergonomic interventions on mechanical back pain and functional disability among the staff nurses. So myself, Stella, the Department of Medical Surgical Nursing. So before starting, so it is among the staff nurses because I am the one of the staff nurse. So introduction. So why I have taken the study is, so it is a lifetime privilege of mechanical back pain in the United States, about 60 to 80%. So for that, the ergonomic deals with the interaction of technological and working situation with the human beings. Ergonomic exercises include hand stretch, arm stretches, and back stretches. So the need for the study is, according to India, results among 384 staff nurses to 85 nurses have the low back pain. So as a staff nurse, they will be carrying the patient for every illness. So they will not keep upon their health. So they maybe leads to the low back pain. So my study is a study to assess the effectiveness of ergonomic interventions on mechanical back pain and functional disability among the staff nurses at selected hospital in Chennai. So the objectives are to assess the level of mechanical back pain and functional disability among the staff nurses, to determine the effectiveness of ergonomic interventions on mechanical back pain and functional disability among the staff nurses, and to find the association between the post-test level of mechanical back pain and functional disability among the staff nurse with their selected demographic variables. So the operational definitions are effectiveness, ergonomic interventions, then mechanical back pain, functional disability, and the staff nurses. Here the staff nurses are GNM, BSc, and the post basics.
So especially who are all in the primary duty is to take care of the patients in emergency, trauma, ICU and OT. So the hypothesis are there is a significant difference between the pre-test and post-test level of mechanical back pain and functional disability after the administration of ergonomic interventions among the staff nurses, and there is a significant association between the post-test level of mechanical back pain and functional disability with selected demographic variables among the staff nurses. So the delimitations are sample size is 30 and data collection period is to 1 month. So review is under the literature, effectiveness of ergonomic interventions on mechanical back pain, functional disability, and related to the literature on both. So the conceptual framework are modified King's goal attainment theory 1981. So the methodology is research approach, quantitative research approach, and the design is
Experimental one group pre-test and post-test design. So research variables are independent, which refers to the ergonomic interventions among the staff nurses, and dependent variables to the mechanical back pain and functional disability among the staff nurses. So setting is Wilroth Hospital in Chennai, population is staff nurses, sample is staff nurses between 25 to 40 years, sizes is 30, and technique is non-probability purposes sampling technique. So inclusion is the age is between 25 to 40 years and overall experience the back pain and functional disability, and overall coming under the minimal and moderate disability. Exclusions are overall not willing to participate and overall known cases of orthopedic disorders like spinal injury and surgeries. So that is the description of the instruments are, first one is demographic variables, and the second one is numerical pain scale, and the third one is functional disability, which is assessed by the Oswestry low back pain disability questionnaire. It is a structured questionnaire. So and the fourth one is ergonomic interventions. So it includes the quadriceps stretch, hip flexor stretches, abductor stretch, arm stick stretch, and dynamic arm stick stretches. So these are all the things which is comes under the ergonomic interventions for the mechanical back pain and functional disability. So the validity is assessed by the experts from the nursing and medical, and the reliability is 0.84 and 0.90. So the pilot study is conducted in the Mada Hospital with 5 staff nurses, in which purposive sampling, and the tool was found to be appropriate to proceed to the pain study. So the data collection period is for 4 weeks, and the location is Wilroth Hospitals, and the steps is first we assess the staff nurses for the mechanical back pain and functional disability, and the pre-test was conducted by using the numerical pain scale and Oswestry low back pain disability questionnaire. Then the ergonomic interventions were given for 1 month for a period of 30 minutes. Then again the post-test was conducted after the 1 month by using the same numerical pain scale and Oswestry low back pain disability questionnaire. So the data analysis and interpretation. So the first one is frequency and percentage distribution of the selected demographic variable, and the second one is pre-test level of mechanical back pain, then post-test level of mechanical back pain, then pre-test level of functional disability, then post-test level of functional disability. Then there is a comparison of mean and standard deviation between the pre-test and post-test level of mechanical back pain. Then again the comparison of mean and standard deviation between the pre-test and post-test level of functional disability, and there is an association of post-test level of mechanical back pain among the staff nurses with their selected demographic variable, and their post-test level of functional disability with their selected demographic variable. So these are all the frequency and percentages. So this numerical pain scale, and this is the Oswestry low back pain disability questionnaires. So these are all the steps in the ergonomic interventions. Quadriceps in the standing, side lying, prone, and hip flexor stretches, abductor, hamstring, dynamic hamstring. So there is a discussion. The first objective was to assess the level of mechanical back pain and functional disability among the staff nurses. So here in pre-test, the pain will be in the moderate is high. So the moderate pain is 80%, and in the post-test, so it was reduced to the mild pain.
So this is the frequency and percentage distribution of pre-test level of functional disability. So all the samples falls on the moderate disability. So the 100% is moderate disability, and after the post-test level of functional disability, the moderate level is reduced into minimal disability. That is 80% in minimal disability and 20% in moderate disability. Then the second objective was of the study was to determine the effectiveness of ergonomic interventions on mechanical back pain and functional disability among the staff nurses. So here the mean and standard deviations. So in the pre-test it is 5.34 and it is in a standard deviation 1.19. In post-test it is 3.032. In a standard deviation 1.07. So the test value of 21.07, which was very highly significant at p less than 0.001. So the next one is functional disability. So here the pre-test is 14.5, mean and standard deviation is 1.4, where in post-test 5.9 and 2.9. The t-test value of 17.67 was highly significant at p less than 0.001 level. So the third objective of the study to find the association between the post-test level of mechanical back pain and functional disability among the staff nurses with a selected demographic variables. So there is an association which was found between the age and the post-test level of pain with the chi-square value of 7.85 at the level of p less than 0.02, and with the marital status, the post-test level of pain with chi-square value of 6.90 at the level of p less than 0.01, and the type of family and the post-test level of pain with chi-square value of 4.59 at the level of p less than 0.05. So this is the association of post-test with their selected demographic variable. So the association was found between age and the post-test level of functional disability with a chi-square value of 6.34 at the level of p less than 0.05, and their marital status and the post-test level of functional disability with chi-square value of 7.03 at the level of p less than 0.01, and year of experience 8.86 at the level of p less than 0.02. So in nursing practice and administer and the research, so we recommended this study can be extended to different people. So the limitation is the researcher was unable to take samples for the study due to time constrictions. Thank you. Thank you.
Any questions? Okay, good presentation.
Before we proceed, can I ask the audience to please settle down? We are having a lot of disturbance. Kindly please cooperate. It's just a few more presentations to go. Yeah, please settle down, guys. Yeah, this side, the side of my left. Please settle down over here. Yes, thank you. Okay, so next we have Professor Mrs. Bhuvaneshwari D. Her presentation to identify the factors associated with nosocomial infection among health workers. And next, I would like to invite Ms. Maheshwari. Ms. Maheshwari. Okay, so next I would like to invite Mrs. Leena Rose to have a presentation ready. So I'm handing over the presentation to Mrs. Bhuvaneshwari.
A warm good evening to one and all gathered here. Myself, Bhuvaneshwari, representing from Ratnama College of Nursing, Andhra Pradesh. Okay. So introduction, hospitals should do the sick no harm. It's a good say by Florence Nightingale. Good health depends on the part of safe environment and practices or techniques that control or prevent transmission of infection, which helps to protect the clients and healthcare workers from disease. And what is the need of the study? So nosocomial infection or hospital-acquired infection are commonly transmitted when hospital officials become complacent and personnel do not practice correct hygiene regularly. Also, increased outpatient treatment means that people who are hospitalized are more ill and have more weakened immune systems. That may have been true in the past. Moreover, some medical procedures bypass the body nature's protective barriers. Since medical staff move from patient to patient, the staff themselves serves as a means for spreading pathogens. Essentially, the staff act as vectors. 1/3 of nosocomial infection are considered preventable. The Centers for Disease Control and Prevention, CDC, estimates that 2 million people in the United States are infected annually by hospital-acquired infection, resulting in 20,000 deaths. The most common nosocomial infection are of the urinary tract, surgical site, pneumonia, and bloodstream infection. And next, what is the need for the study? So according to CDC estimation, in France, the nosocomial infection ranged from 6.7% to 7.4% in 1990. And moreover, in 2006, the most common infection were urinary tract infection, and then infection of surgery site, infection of the skin, mucous membrane, and respiratory infection. And we have bacterial infection. And it also been estimated that 4.5 additional days have been increased in patient stay, and about 9,000 people died every year with a nosocomial infection. And what is the statement of the problem is, the study to identify the factors associated with nosocomial infection among health workers working in Shananagar Health Center. And what are the objectives of the study? The first objectives of the study is to identify the factors associated with nosocomial infection. And the second objective was to associate the factors associated with nosocomial infection with the demographic variables. And what are the variables or independent variable and the dependent variable? We have the independent variable are the factors associated with nosocomial infection, such as the standard precautions or the pre and post-operative practices, and then labor and delivery practices practiced by the health workers. And then dependent variable is the nosocomial infection. Operation definition, here it's identify factors, nosocomial infection, and health workers, and then health center. And the researcher have formulated the null hypothesis that there is no significant association between the factors associated with nosocomial infection and demographic variables. And the delimitation, the study was delimited to Shananagar Health Center, and it was delimited among the health workers working in Shananagar Health Center. And what are the methodology approach used in these researches? Research approach is explorative research approach. Research design is descriptive research design. And the variables, we have already seen the independent and dependent variable in this research study. And the research setting, already it said that it is delimited to Shananagar Health Center, and the population, target population is all the multipurpose health workers, and the accessible population are the multipurpose health workers working in Shananagar Health Center. And the sample size comprises of 20 health workers who were working in Shananagar Health Center. And the sampling technique is non-probability convenient sampling technique. And the development of the tool, the section A comprises of demographic variables, and section B comprises of modified infection control tool. And it has the 3 factors, especially pre and post operative practices, labor and delivery practices, and standard precaution factors. Each practice checklist will be having a 20 questions, and it is self-observational checklist. And the data collection procedure, and all the formal permission was obtained, and the questionnaire was explained to the health staffs, and the investigators selected 20 health workers by non-probability convenient sampling technique, and the data was collected from the health workers who fulfilled the inclusion criteria by observational checklist, and the brief introduction was given and confidentiality was maintained. And data analysis procedure, frequency and percentage was used to analyze the factors associated with nosocomial infection. And then chi-square test was used to associate the factors associated with nosocomial infection with demographic variables. And the data analysis and interpretation. Here, the first table shows the frequency and percentage distribution of demographic variables. Here it shows that 55% are having about 20 years of experience and 55% have gained knowledge about infection control through in-service education. And second table, it shows the frequency and percentage distribution of factors associated with nosocomial infection. Here it shows all the three factors, that is standard precaution as well as the labor and delivery practices, pre and post-operative practices are moderately associated with the nosocomial infections among the staff nurses who are working in the health center. And what is the association? When we come to the association point, here the years of experience has a strong relation association with the demographic variables as well as the nosocomial infection factor. So the null hypothesis was rejected. So discussion, the first objective was to identify the factors associated with nosocomial infection. So here I already explained that all the three factors, standard precaution, pre and post-operative practices, as well as delivery and labor practices are moderately associated with the nosocomial infection. The second objective was to associate the factor with nosocomial infection with the demographic variables. Here the factor standard precaution, pre-operative and post-operative practices were not associated, whereas labor and delivery practice was associated with the demographic variables with the years of experience. And recommendation, a similar study can be conducted on a larger sample to generalize the findings, and it can be done to find the knowledge, attitude and practices of the nurses towards the prevention of nosocomial infection. And finally, to conclude, it says that all the three factors, standard precautions, pre and post-operative practices, as well as the labor room and delivery room practices were moderately associated with nosocomial infection. Thank you all.
Very good. Very short and sweet. You made it 2 minutes before also. Excellent.
So next, I would like to call upon Mrs. Lena Rose for her presentation on scientific reason behind the therapeutic diet. I'd like to ask Dr. Pooja Maheset to be ready with her presentation.
Good evening to one and all gathered here. Today I am going to present scientific reason behind the therapeutic diet. So hope you all have heard Tamil quotes. Let food be the medicine and medicine be the food. That is, unave marundu, marunde unavu. This is what I'm going to explain. What is the rationalization and therapeutic scientific reasons behind the therapeutic diet? So everyone very well know about the natural foods contain necessary vitamins and minerals and the nutrients, and also it will protect our body from the some chronic illness. So next I am going to discuss about importance of diet. The healthy diet is essential for good health and nutrition. It protects you against many chronic and non-communicable diseases. So it may also help you live longer, keep skin, teeth and eyes healthy, supports muscles, boosts immunity, strengthens bones, lower risk of heart disease, type 2 diabetes and some cancers, and also supports the healthy pregnancies and breastfeedings, and also helps the digestive system's functions. So here I don't have time to explain all the types of diet. So I am going to discuss about only the hypertension and diabetes mellitus. What is the reason behind the scientific reasons? So first, hypertensive diet The goal of hypertension treatment is to lower high blood pressure and protect important organs like the brain, heart, and kidneys from damage. The effects of sodium and elevates tensions in the walls of the blood vessels. And next, what are the foods to be taken for diabetic patients? Like apples, bananas, carrots, grapes, orange, potatoes, spinach, green leafy vegetables, and yogurt and garlic. For these are all the fruits. What are the scientific reasons behind the therapeutic diets? First one is banana. So in bananas contain plenty of potassiums, and minerals that plays a vital role in managing hypertension. According to the American Heart Association, potassium reduces the effects of sodium and elevates the tension in the walls of blood vessels. And next one is watermelon. So watermelon contains an amino acid called citrulline, which may help to manage high blood pressure. The citrulline helps the body to produce nitric oxide, a gas that relaxes the blood vessels and encourages a flexibility in arteries, and these effects aid the flow of blood and which can lower high blood pressure. An apple, the polyphenols and potassiums are excellent blood pressure lowering elements. And citrus fruits. So the citrus fruits including oranges and grapes and lemons are high in phytonutrients such as carotenoids, flavonoids, and polyphenols. These nutrients are types of antioxidants, may have powerful blood pressure lowering effect, and also it helps to manage blood pressure lowering level and keep your blood vessels healthy and flexible, promoting good circulation. And next one is potatoes. The potatoes are high in that is chlorogenic acid and then anthocyanins, chemicals that helps to lower blood pressures. The dietary caffeoylquinic acid reduce the oxidative stress and improves nitric oxide bioavailability by inhibiting excessive production of reactive oxygen and spaces in the vasculature and leads to the attenuations of endothelial dysfunctions and also the vascular hypertrophy. And next one is onion. The onion contains antioxidants and the compounds that fight the inflammations and decrease the triglycerides and reduce the cholesterol levels, and all of which may lower the heart disease risk. Their potent anti-inflammatory properties may also help to reduce the high blood pressure and protect against blood clots. In carrot, they are excellent source of nutrients like a potassium, antioxidants, and vitamin A, among many others. The beta carotene, a type of carotenoids, is the nutrient that turns carrots orange and also promotes the health. And these carrots, the resistance of LDL to oxidations is increased by high dietary antioxidants intake, so that carotenoids, it is one of the part of lowering blood pressure. And next one is green leafy vegetables. In green leafy vegetables are rich in nitrates, which helps to manage blood pressure. Examples of leafy green include like cabbage, collard greens, and fennel, lettuce, mustard greens, and spinach. The spinach is naturally rich in compounds called nitrates. These may help improve blood flow and pressure by relaxing the blood vessels, reducing the arterial stiffness, and promoting dilations. A reduction in blood pressure helps reduce the risk of heart disease and stroke. And next one is pulses and lentils. The pulses contain high levels of protein and essential nutrients such as fiber, folate, calcium, iron, and vitamin C. These nitri pulses have a low glycemic index and saturated fat content and are high in fiber, potassium, and plant protein, each of which independently confers blood pressure lowering effects. And lentils The lentils and legumes are very rich in both soluble and insoluble fiber, and this bring down LDL and bad cholesterol in our body. And lentils have a capability to alter physical properties of blood vessels, thereby regulating flow of blood, oxygen and nutrients. And next one is, what are the other foods lowering the hypertension, like a garlic? So garlic is a natural antibiotic and antifungal food, and also it will increases the body's production of nitric oxide, and which helps the smooth muscles to relax and blood vessels to dilate. These changes can reduce the hypertension. The garlic extract reduced both systolic and diastolic blood pressure in hypertensive people. And next one is chocolate. So many people, we won't give chocolates to the patients, but here the polyphenols, in particular flavonols in cocoa product, have been shown to increase the formation of endothelial nitric oxide, which promotes vasodilation and consequently may lower blood pressure. So it will conclude the cocoa rich foods may reduce the blood pressure. And next one is fermented food. Fermented foods are like a probiotics, and the products can improve the blood pressure through mechanisms including improving the total cholesterol and low density lipoprotein cholesterol levels, and reducing the blood glucose level, and also insulin resistance, and also regulating the renin-angiotensin systems. And next one is fermented rice water. In fermented rice water, there will be lowering the blood pressure. The magnesium and the selenium present in the fermented brown rice strengthen the bones, and since it is light on the stomach and digestive system, it also helps in eradicating the ulcer. And next one is, what are the foods to be avoided for this hypertensive patients? Like everyone know about, we have to give the salt restricted diet. So here sodium can significantly raise blood pressure. Lowering salt intake by 4.4 grams daily subsequently reduces systolic blood pressure and also the diastolic blood pressure. The following foods known as the 5-6 salty foods, that is bread, rolls, pizza, sandwiches, gold cuts, and cured meat, soup, and then barricades and tacos. These are all the foods, they are highly salt. So that's why we are avoiding the foods. And next one is coffee. So coffee can increase both systolic and diastolic blood pressure for 3 hours after consumption. So next one is processed food with trans or saturated fat. To keep the heart healthy, it is best to reduce the saturated fat and to avoid the trans fat. The saturated fat also increase the levels of LDL cholesterol in the blood. And next one is a pickle. Most pickles are high in sodium, so it is important to really limit the consumption. People with high blood pressure or cardiovascular health issues may want to avoid the pickles. And next we'll discuss about the diabetes mellitus. So here we'll discuss about the importance of diet. The plan helps you control your blood sugar, manage your weight, and control the heart disease risk factors such as high blood pressure and high blood clots. And what are the foods to be taken for the diabetes mellitus patients? That is, non-starchy vegetables are one of the best foods you can eat as a diabetic, like and then leafy greens, fish, and then nuts and eggs, seeds, natural foods, natural fats, and apple cider vinegar, and then turmeric, and fruits and vegetables, whole grains such as wheat, brown rice, barley, and oats, and proteins such as lean meat, chicken, fish, and then egg, nuts, beans, and lentils, and non-fat or low-fat dairy such as skimmed milk, and then papaya and guava. The papaya and guava, that is ethanolic extracts of stem, have a high anti-diabetic activity. Guava contains a large number of antioxidants and phytochemicals including essential oils, the polysaccharides, minerals, vitamins, and enzymes, and that is triterpenoid acid, alkaloids, steroids, glycosides, tannins, flavonols, or spanoons. These are all the chemical actions in the papaya and guava. And then papaya fruits contain flavonoids. It will help to natural antioxidants that may help to regulate the blood pressure level. So here, physical inactivity and unhealthy diets are major contributors of overweight. So overweight and obesity are major risk factors for a number of chronic lifestyle diseases. Hence, the growing prevalence of diabetes, hypertension, and cardiovascular disease, and some cancers tied to excess weight. Thank you.
Very good. Thank you so much for the back benches. It is a need of the hour of the study, actually, because we need, as per the sustainable development goal, we need to have a nutritious food, eradicating the poverty, and good health and mental well-being. This is the most important thing which you presented, ma'am. Thank you so much for the topic.
So next, I would like to call Dr. Pooja Mahaset to present her paper on prevalence and awareness study about imposter syndrome among physiotherapy students and professionals, a cross-sectional analysis. Thank you.
Shall I start? Okay. Greetings of the day to everyone. Myself, Dr. Pooja Mahaset. Today, I'm presenting a paper on prevalence and awareness study about imposter syndrome among physiotherapists, students, and the professional. So basically, imposter phenomenon describe the individual mistreat their capability and achievement despite of their competency and success. So those people who are having imposter syndrome, they won't celebrate their achievement. They'll be always having this feeling of fraud and won't celebrate their achievements. So it was first introduced by a clinical psychologist, Clance, and also that he have came up with a scale called Clance Imposter Scale to measure the intensity of imposter syndrome. So one author have suggested that from 9% to 82% of individuals experience imposter syndrome at some point of their life. So imposter syndrome include feeling of self-doubt, inferiority. This syndrome exhibits a fear that someone exposed them as a fraud and drive them as a sense of anxiety and depression. So in order to get successful, physiotherapists need to contribute enough time for their extensive reading, highly skilled and working tirelessly. So imposter syndrome doesn't spare anyone in their career. And it says to like those people who are having higher IQs or those people tend to be much smarter. Those people tend to suffer more from imposter syndrome than the people with the average IQs. So in order to acknowledge this feeling of imposter syndrome within physiotherapy field, we attempt to explore imposter syndrome among the entire physiotherapy professional ranging from a student, trainee, researcher, academician, and other clinician in the practice. The aim is to find out the prevalence rate, educate, and spread awareness of imposter syndrome among physiotherapy student professionals by identifying and understanding imposter syndrome. It is very important because more than 90% of people are the sufferer from the imposter syndrome, but they are not aware about this imposter syndrome. Also to find out the effectiveness of innovative physiotherapy treatment protocol for healthcare professionals. Question is the important to understand and identify about imposter syndrome among healthcare professionals. So these are the literature which supports my studies. There was one study done in 2019. It's a systematic review in which Dina M, the author, has said that day by day, people are the more suffer from imposter syndrome. And we can see the scale, how it is going. So from 40 to 50, it is like moderate. Below 40, it is low. Above to 60 is severe, and above to 70, it's intense. It's a cross-design study, observational type for 6 months for the sample size of 338. Inclusion criteria are postgraduate student, faculties, academicians, researcher. Age group is 18 and above, both genders. Outcome measures were taken are self-reported imposter features and Clance imposter phenomenon scale. So the procedure was the client's imposter scale was taken and everyone was asked to fill the paper. Those people who range from below 40 was like a low sufferer from imposter, above 40 was the mild, and from 40 to 60 was moderate, and 60 to 80 was frequent, and more than 80 was the intense sufferer. So these data shows the age group from 18 to 28 are the more suffer from imposter syndrome. Table 2 shows that females are more sufferer than male. Table 3 shows that among 338% of the people or 100% of people, more than 90% of the populations were having moderate imposter syndrome. The other data shows so in discussions, we found out that prevalence and awareness of imposter syndrome among physiotherapy students and professionals. In survey of 338 participants, we found out 31%, 32% of participants have a significant imposter syndrome. 58 has moderate. Almost everyone has imposter syndrome, I can say that. But yeah, when it was calculated, in 199% were unaware about having imposter syndrome. Only 1% was aware of imposter syndrome, though they don't know the treatment of imposter syndrome and how to overcome it. So this is a rise the area of interest in research to increase the focuses of physiotherapy well-being and awareness of their mental health, and to find out the contributing factor for burnout, anxiety, and depression. As a result of our study shows that imposter syndrome was the most common in women than men. This study goes with the hand with Oriel, the author Oriel. This study also shows that the author which has shown that the significant prevalence of imposter syndrome among professors and students are greater. And out of 338 participants, majority of participants has a moderate imposter feeling, and this shows that at least had some experience of imposter feeling at some point of their life. Finally, literature described that harmful association between the imposter feeling, job performance, satisfactions, and burnout among physiotherapy students and professionals. With this evidence, all university and institutes should coach and train imposter phenomenon among the professionals. Through the community support and coping strategies, the individual of imposter phenomenon change over a time, and this can improve their well-being. Lastly, the conclusion says that imposter phenomenon is widely recognized within the physiotherapy professions. This study concludes the prevalence, the possible causes, and acknowledgement of professional regarding better understanding of imposter syndrome, feelings, and symptoms among physiotherapy students and professions. So, when a person is with imposter feelings or syndrome, what they think they know, what others know. So I would like to say it's okay to not know everything. These are the reference of my studies, and these are some tips for overcoming imposter syndrome which I came up with, like sharing their feelings. Group therapy can be given, along with that talking with a mental health expert, challenging or changing their negative thoughts, learning to accept the facts, and to be aware about the symptoms. Thank you for listening to me.
Very good. It's a very good study. Actually speaking, it is not a people syndrome. It is professional syndrome where we have stress, anxiety, and it is everyone has. Actually,
that's what among, like, we all are sitting over here, no, more than 90% of population are sufferer, but they are not aware about this imposter syndrome. That's why I did this study to find out, and I was like, right, and they don't have like how to overcome this imposter syndrome. Even I was the sufferer, yeah, but I worked for myself, and now I'm from moderate, I came to the mark.
Very good. Good study. Actually, it is a need of the hour, because COVID pandemic, during the pandemic also we had a lot of stress, because due to loss of job, loss of money, and due to that children, family members, parents, geriatric, everybody had that stress related hypertension. A lot of problems, which there is a problem and lack of professional supports for counseling. And due to that, National Institute for Empowerment of Persons with Multiple Disability, NIPMED, we have Kiran Mental Health, 24/7 counseling services through the psychologist, clinical psychologist we are providing. And this is a good study you conducted.
Thank you so much, sir. Thank you for listening.
So with that, we have concluded the scientific session of day 1. So thank you to all the presenters and thank you to the audience for listening patiently. We've had some wonderful topics and wonderful presenters who have presented their work on the topics that they have chosen. I would like to thank our session chairs for them presiding over both the sessions that have happened, and a warm thank you to all the presenters for your work and for spending your energy and effort in presenting your works. And to the audience, a huge thank you for sitting through the presentations and cooperating as much as possible with us. It has been a very wonderful first day. I would like to conclude on that point. May the second day also be a very good day, and may we have a lot of different presentations as well. With that, we will be concluding day 1. So thank you everyone, and to all the presenters tomorrow, all the best. And we hope that this convergence will conclude tomorrow on a happier note. And so stay safe and take care everyone. Thank you. Okay, thank you.
Students, listen, tomorrow you have a virtual session. We'll forward the Zoom link. Okay. So that's all. Thank you so much. So all Indians can stay back. Or 10 members in the morning. That students stay back, others can go. நம்ம எங்க லிசனே பண்ணலன்னு நினைக்கிறேன், முடிஞ்சிருச்சு எப்பயோ கதை பேசிட்டு இருந்தோம். Here there is a conference. Go.
Just give us a minute.
நம்ம